So I'll let everybody in and we'll go ahead and get started. Good morning, everybody.
Good morning.
Good morning.
Good morning.
Hey.
We're just gonna let all these people join for another minute or so, and then we'll go ahead and get started.
Sounds good. Let me know, Michelle, when to call the meeting to order.
Sounds good. Okay, I think we can go ahead and get started, Ian.
Okay, great. I will call the meeting to order. Welcome everyone to our June Medicaid provider rate review public meeting. And let's start by confirming that we have the Mprrac members. So I am Ian Goldstein, the chair of Mprrac. Do we have Christopher?
I'm here, Ian. Christopher Maestas.
Hi, Christopher. Do we have Manisha?
Looks like she's here. She's muted, Manisha. Can you hear us, Manisha?
Can you hear us? I see her as well. Let's just assume she's here and we're
Yeah.
going to get off mute. Do we have Megan?
Good morning.
Good morning. Do we have Tim?
Ela acrescenta kami.
Do you all see Tim in the attendance list?
I do see him here, yeah.
You do. Okay, great. And then I believe we are not going to have Kate today. Is that correct?
That is correct. Yeah.
And then we have our new member, Nicole. Are you there, Nicole?
Hi, yes, I'm here.
Hi, Nicole.
Welcome.
Hi.
Okay,
Thank
I
you.
think we have a quorum and we can go ahead and get started. So I will pass back to Michelle and Brian.
Great. Thank you so much, Ian. Okay.
Michelle, before we get started, I have one quick question.
Sure.
I noticed there's an AI note taker on the list of attendees. I just
Yes.
can't remember what the story of that was. I just don't want to point it out though.
Yeah, thank you. So we, with the world of AI, we can't really stop people from using them, but we don't recommend referring back to AI notes in regards to what happened at these meetings. We will post the official notes on our website afterwards. So if there's ever any questions about what was discussed, please refer to the meeting notes on our website and try to steer clear from the AI notes, just in case they get it wrong.
Okay, that's what I thought. Thank you.
Thank you. All right, next slide, please.
Michelle, this is Tim.
Yes, hi, Tim.
Hey, how are you? I have to drop about 15 minutes, right around 10:15 for an unexpected system meeting, but I
Okay.
will in right after I'm done.
Okay, sounds good. Thank you for letting us know. All right. Okay, so here's our agenda for today. We'll go through some meeting structure and logistics like we normally do. This was announced to the public and also announced on our website. Our goal today is to get through the ASC category. There's a chance, depending on the timing of stakeholder feedback and how many people we have to sign up to speak, that it will get pushed to the 7:10 meeting. And if that's the case, then we'll start with ASC next time, but our goal is to get through ASC today. And we will take a lunch break around 11:30 for 20 minutes. And we understand these meetings are very long. If you can't stay for the whole thing, please feel free to email our group email address there. It's also in the chat as well. And that will always be passed on to the Mprrac as well. So if you can't say your public comment here, email it to us. It will still get shared. And then we'll go through some next steps and adjourn right around 2. So we have some announcements. We have a new Mprrac member. Her name is Nicole Hardy-Swan, and we're very excited about her joining the committee. If you'd like to introduce yourself, Nicole.
Thank you, Michelle. My name is Nicole Hardy-Swan. I am a clinical psychologist. I reside on the western slope of Colorado and provide services with mental health, speech therapy, physical therapy, occupational therapy, and ABA therapies for pediatric patients.
Hello.
Thank you so much, Nicole.
Welcome,
it's like
Nicole.
Polka dot bag.
Thanks, guys.
You can just leave it at mom's.
Make sure we are all muted as well. Okay. And then we also have two HickPuff employees that are new. So I'd like to have them introduce themselves as well. Andy?
Hi, good morning. I'm Andy Cochran. I've joined the team just this month, so I'm pretty new, but happy to be here and working with all of you. Thanks.
And Bria?
Yeah, hi, I'm Bria, and I started the same time as Andy, so I've only been here for a few weeks, but I'm excited to be on the meeting and get a little bit more sense of how this all operates.
We're happy to have all you here. Okay, next slide, please. Okay, so just the normal housekeeping rules. Follow along the updated appendices, which are posted on our website. I will drop that link in the chat right after I'm done speaking. And if you are part of the Mprrac, please edit your name to say Mprrac member so the public can see who's who. Public stakeholders, we do have quite a few who are signed up to speak, so it's really important that we stay on our 2-minute time limit. This is just to make sure everybody has a chance to say what they need to say. We don't want to, gyp anybody, so please adhere to that rule, 2 minutes, if you're signed up to speak publicly. Again, if you have extra information that you want to send, you can always email it to us. It will be shared with the Mprrac. Identify yourself before speaking. Please do not share any PHI. Remember, we're speaking in broad terms in these meetings, not individual. If that does happen, there is a way we can remove it from the recording, but it does take a little bit of extra time. So just to keep the process moving, please try not to share any PHI. And if you have questions specifically about, any of the categories or the data or anything like that, please use the Q&A feature instead of the actual chat box because things tend to get lost in the chat. So use the Q&A if you have questions. Next slide. Okay, and I don't think Dylan is here. Let me just double check. No, okay, so Dylan is our accessibility technology specialist. He is the one responsible for editing these materials after our meetings to make sure that they are accessible. So just as a heads up, as always, we're going to repost them after the meetings once we do a full review. And we'll get them reposted on our website as soon as we can. Okay, and I think Kevin Martin, I think you're up next.
Hello. So I just wanted to give a little update on budget realities and just sort of what happened last year, exactly what we're doing here, and that kind of thing. So first off, I just want to be really clear that, Mprrac is not the only way that the department or the state as a whole adjusts rates. This really is a forum to make sure that we actually get to everyone and review everyone on a timely basis, but just the realities of budgeting and the time frames that we have to work within, they sometimes move faster than a 3-year rolling cycle. So we have to do things outside of Mprrac sometimes. And then I also wanted to just talk about last year. We had a pretty bad budget year. It's looking like this year is also going to be pretty bad. And based on what happened last year with all the recommendations, we weren't able to act on any of them. I don't want to change anything about the recommendation process. I'm not asking you to, or you as the committee, to try and weigh budget concerns or anything like that. We still want to hear all of your opinions and the unfiltered recommendations. I just would ask maybe if you could give us maybe just a little bit more context so that, if there is a slight chance that we can do like one thing, or if there's a way to do something that's like a little bit less than the overall like biggest priority, or not biggest priority, but the overall biggest ask, like if there's a smaller ask that you would be okay with, just anything along those lines that would just give us a little bit more information that maybe we can do something, then that would be helpful. I'm just trying to look for a way that we can do something instead of just saying, well, we can't do anything from Mprrac because we don't know like how everything falls, and all of it together is a $50 million price tag. So it's either throw it all out or nothing, I guess. So that's just my only plea here, is just if you can give us a little bit more context so that we can hopefully pick pieces out of it that we might be able to accomplish.
Kevin, I think that's helpful, and I want to make sure our recommendations are helpful to the department. I wonder if, just hearing you say that, I wonder if my thought was maybe at the August meeting we save 30 to 45 minutes just to kind of up level across the recommendations and say, this is we could do one or two things, like here are the stars we would put next to it. So we basically review every service the way we were already planning to this meeting and upcoming meetings. But at the very end, we just kind of step back and say, across all the recommendations, it's X million dollars. We know the state has ongoing budget challenges, and this would be the committee's top one or top two or whatever things. Would that sort of thing be helpful to you all?
Absolutely. That would be great. And, I guess I bring it up here just in case there are or bring it up here instead of in the August meetings, in case there are like multiple options you want to consider. Obviously, we're not going to be able to do, like a huge range, but if there's two different things you want to look at, then we can definitely like bring back impacts on those two different things.
Okay, that sounds good.
I need to say, like, it feels like over the last several years we've been working on sort of coming to an agreement about a sort of standard methodology for deciding on our recommendations for valuations of these codes, and I'm kind of curious if there is like anticipated any additional like legislative guidance or anything like that, because I definitely understand the challenges that the state is in, and how difficult last year was with that significant discrepancy in our recommendations. And I do think that the department did a nice job of trying to run the balance and come up with, something that tried to work toward that spirit, and kind of dealt with the realities that we're having. I think my concern is that if we are making recommendations within, a budget constrained year, the codes that happen to come up during that period of time get treated differently than codes that we might look at a different, when the state is sort of in a different situation.
So first off, thank you for recognizing that. And yes, we are absolutely doing our best within a difficult situation. As far as having more of like a structure to it, I would say that there are a lot of conversations, there are a lot of opinions. There's really not a consensus at this point. I would sort of, this is just me speaking, this is not like, I guess, anything that I've heard officially. I would imagine that there is going to be some kind of concerted effort to come up with a consensus here. the near future, as in like the next couple of years or something like that. I'm really not sure, but I absolutely have seen the exact same thing, that there is a lot of shifting opinions on exactly how we should do this. Like, people are becoming more familiar with exactly what Mprrac does, and trying to utilize it more. It's just that different people have different opinions on exactly how it should be used and how those details should happen. And so I think it just needs more time for those people to come to a consensus. And by those people, I'm talking about, like, the high level state leadership, like the JBC legislature, the governor's office. And we're also going to have a new governor here next year. So there's probably going to be new opinions there. But this has also just been a challenge since the beginning of Mprrac. Like, back in, what was that, 2015, even before we moved to the 3-year schedule. It's been constantly evolving ever since the beginning.
Manisha, do you have your hand up?
Yes. Do you hear me now?
Yes.
Yes.
Awesome. Great. Thank you. I am going to second what Dr. Megan was just talking about, that this year, the codes that are being reviewed, I was wondering, and I know you said there's no consensus as such that what the process is going to be on a year when we do not have as much of constraints. As the recommendations are finalized, can we at least say that, yes, we accept this, and then assign a percentage to it, that, but we are going to go off of this percentage of the recommended fees just because of the budget constraints? And once, being very optimistic, say next year or the year after, if we do not have these constraints, instead of waiting 3 years, we go off of what the initial recommendation was and just take off the percentage of what we had to add because of the budget.
I mean, you have complete freedom to make whatever recommendations you want, and we will absolutely include those recommendations in the report. As far as exactly how those recommendations filter up through the various layers in the decision-making process, I don't really have much control over that, because it sort of goes up through the department and then through the governor's office and then through the legislature. So, like, just the way that the government hierarchy works at any point in that process, it could be just, the path could be altered, I guess. And we even see that, as we are developing the report and putting it together with just the department recommendations, because it is a consensus of a large government body. It's not just one person, or even just like a small committee.
I understand. So, and I am not saying as Mprrac we keep a blind eye to the budget, but then I am just reiterating my thoughts here that, yes, I want the budget realities to be understood, but at the same time, I do not want Mprrac recommendations to go purely off of budget just because of this reason, that 3 years we do not want these codes to be like, okay, these codes are not being touched at, but that year Mprrac was not as liberal with their recommendations because of the budget.
Absolutely. And I don't want to put constraints on you either. That's why I'm saying, if we could just get a little bit more. I'm not asking you to change anything about like what your actual desires, what your actual recommendations are. Just sort of like, well, here's what we want, but if there's some way that we can't get that, what else could we do?
Fair enough.
Just so that, again, like I was saying, if we take everything as a whole and look at it as like a $50 million price tag in a down budget year, it's either up to us to try and prioritize that, and it may not necessarily align with your priorities, or we just have to throw it out completely. And that's sort of what happened last year, is just that we had this big price tag on it, and we couldn't move forward with it as like one big package.
I think we should wrestle with that, while also I think Manisha's point is important that, we're supposed to we don't make the budget, we don't do anything with the budget. So I lean towards doing a couple things just here in the conversation. One would be where we can making kind of a budget independent recommendation, and then which I think should largely be consistent with how we've approached things in prior years, as Megan mentioned, and then have a budget considered or a lighter recommendation or something like that. That'd be one thing I would do. And then a second would be having this kind of look back conversation in the August meeting to say across all categories, what do we as a committee think is the most important? And I think that would be helpful because we spend a lot of time on this. We want our recommendations to turn to real action. And I just don't think we spend all this time on it. Let's not recommend $100 million in budget that's not going to be passed in. It's just like, it's not a good use of time. And so I think in the spirit of being helpful to the state, I think doing those two things would be beneficial, but let me know if anyone disagrees.
I agree. I think that we do need to make some recommendations that are realistic, and I agree. We just need to somehow figure out a way to flag when there is sort of a decision that's driven more by the realities of our budget than by sort of the ideal state.
Okay, sounds good.
Well, thank you. That was a great conversation, and thank you for being open to giving us a little bit more to work with. That again, we put a lot of into it on our side too. So we want to make sure that we're working through everything so that we can make this as useful to everyone as it possibly can be.
Sounds good.
All right. Thanks, Kevin. Thanks, everybody. All right. Well, we'll move forward. Just a quick reminder, this has been said now a little bit, but this is a legislatively appointed body, functions collaboratively with the department, but not department staff. And the rate review staff is tasked with synthesizing all the actuarial analyses into the reports and information that we share today. Those help develop the recommendations which come out of the meetings here in June and July. And then they may result in future budget actions by the department, but rate changes are always approved and appropriated by the legislature as per state law. And then just review services includes analysis and recommendations. These do not guarantee any changes, whether increases or decreases. Remember, we do not submit budget requests out of the Mprrac. That's out of scope for us, and the department budget is separate and independent from our rate review process. We do not have the authority to change rates without the legislator and their approval and appropriation. We've been really good on this over the last few years. And just as a reminder, we do seek for the Mprrac committee members to self-govern as much as possible and keep a respectful, safe environment. We want folks to stay on mute unless you're engaging directly. Be tough on the problems facing our state and easy on each other here. We use the past to help describe a future that is better. And everyone has come prepared, reviewing the materials in advance and making sure you're sharing input from your community, your stakeholders, and your colleagues, even if they're not here. Just a reminder, our terms structure is up for some changes in the next year. And you can see here, if you're highlighted in orange, either appointed by the governor or the speaker or the president of the Senate, each of these roles and terms is coming up in 2027. So We are thinking about if folks want to seek another term, then we can help with that process. If others are looking for this, or there's others that may be interested, we would want to entertain that as well. Michelle.
Yeah, sorry, just wanted to make a clarification. When I was making this slide, I kind of got confused with what I was doing. And I highlighted Ian's term here. So your term is not ending next year, but I highlighted it thinking I was highlighting it because you're interested in serving another term. So just wanted to clarify, yours is not ending in 2027, it's 2028. But that you're interested in another term that we discussed.
Sounds good. Thanks.
Yeah. So again, let Michelle know if there's interest in these, and it looks like there is. So we're excited for that. Thanks, everyone. All right. So this is our annual meeting structure. Follows really how we've done it the last few years. There is this change. Of course, our March meeting, we shared some preliminary data, and we've shifted now in June and July to 2 meetings in this cycle. That allows us to go deeper on supplemental analyses and get recommendations that are a little more nuanced and provide more opportunity for feedback from the public as well. So we've extended this to 2 days in the last 2 years, and that seems to have worked, although it's still tight on time sometimes. So I want to remind everyone to be judicious about that. And then in August, we'll come back again and share refined recommendations and the fiscal impact of those. And then in November, as always, we do our lessons learned and plan for 2027. Yep, thanks. So the purpose for today, remember this is a 2-part meeting, so you will have additional background and analyses, and we'll have some definitions on the recommendations that we will make. We're looking to hope to get up to dental today, but not cover dental today in the list, and we'll see if we can do that. And then our August meeting, we'll review the fiscal impact of those recommendations. Okay, Christopher.
Okay, so next up, we'll move to approve the March 26th meeting minutes. Those were included in the materials and posted. Are there any corrections? Hearing none, I'll take a motion to approve.
Second.
Okay, all in favor?
Aye.
Aye. Any opposed?
I'm not eyeing the opposed part.
All right, hearing none, motion carries and we'll approve those minutes.
Thank you, Christopher. All right. This is our cycle. We are cycle 2, year 2, and we need approval on this from you all. The couple of notes here that are important to remember. So we basically are struggling a little bit with the services that will be covered and trying to do some balancing and matching. So you'll notice we're recommending to move the 3 TCM targeted case management services from year 3 here into year 2. And along with the HCBS that you see there and home and community-based services to help balance the workload for year 3. Year 3 just has a lot of services, and we're trying to make sure that next year is doable. And this would be very, very useful for us to do. We've carved out all the direct care services under those HCBS and CFC from the impact review process, and we'll review those from the IPAG process consistent with new legislation. And note that we would conduct extensive provider engagement activities in preparation for this 2027 review to help develop any appropriate benchmark state lists for some of the reviewed services. But you can see here, this would cover, transportation, ENT, NEMT, home health services, pediatric personal care, private duty nursing, and so on.
And you just need us to approve this list, Brian?
If you would.
Okay. Any feedback from any committee members on this list? All right, so I think everyone is comfortable with this list, it sounds like.
Yeah, I don't have any problems with this list.
All right, I think we're good, Brian.
Yeah, thanks everybody. It's balancing. I think it'll be glad in a year based on what we have coming then. Okay, thank you. Now, 2026. So this year, right, we have an analysis method. There are some additional analyses that have been completed, and we want to walk through the method and the overview of that before we dive into any of the details. So for 2026, you see NEMT out of cycle review has been mentioned, then maternity, abortion, pediatric behavioral therapy, anesthesia, ambulatory surgical centers, dental, behavioral health services, fee for service only, and then surgeries. And I would just note today we're working to get up to dental, as I mentioned, in terms of this, the review. And just some recaps and new information on the analyses that have been completed and will be shared today and next meeting. So since the March meeting, 23 separate new analyses have been completed by the department, including 7 for NEMT. Maternity has 3. A number of these have 1, abortion and so on. PBT 5, and fee-for-service behavioral health 3. So quite a bit of work has been completed, and we'll be able to share the fruits of all that labor here today and in the next meeting. As a reminder, the department excluded codes without benchmark rates from the rate comparison analysis, but the committee still needs to make recommendations on these so that these excluded codes can be aligned with other codes from the rate change perspective. This is not new, but just a reminder, there are times when we do have benchmark ratios, so we want a recommendation around those for those codes. And then some codes will be fee for service rates, but do not have those benchmark rates. And nevertheless, we do want your input on those as well. And sometimes those take different forms. So just a reminder of how we split the field here. And a couple notes on changes to cover all Coloradans. This, of course, helps children and pregnant people get health coverage no matter the immigration status. There have been changes on certain behavioral health services from ACC and RAY capitation to fee for service, and those will go effective next January. The capitation payments and certain care coordinating responsibilities are removed from the regional accountable entities, or RAYs. And funding is redirected from capitated appropriations to fee for service. Keep this in mind. Certainly, Mprrac is designed to analyze the historical data and not forecast prospective program changes. So this is relevant as we get further into particularly the.
All right. Thank you, Tom. All righty. I'll see you in a bit.
Sorry about that. And then more meaningful evaluation will be possible after the implementation and we get some new data, and that often takes a year or two. So look forward, essentially several years till we can get sufficient sample size and historical data from reports and so on. That wouldn't even be until 2029. Okay, NEMT. Cole, are you there?
I can present on these 2 slides also. So Yeah, so starting out with non-emergent medical transportation, much of this information was in the last March meeting, but some of it has been updated. Just a reminder, the rationale for our approach was a rate-only analysis to avoid distortion from any anomalous utilization patterns, and also to ensure methodological consistency while data stabilizes. In our analysis, just a quick summary, we have 10 benchmark states that we looked at. I won't read them all out, but they're listed right there. And we had 25 total procedure codes, but 5 were excluded because 3 were manually priced and 2 lacked valid benchmarks. The benchmark ratio range has been updated in the table below, and please refer to the Appendix C8 version 2 for a detailed analysis. This table just includes some commonly used NEMT codes. This is the same table that was presented in March, but with the exception that our Medicaid rates are now reflective based on July 1st, 2026, and the updated rate-only benchmark ratios reflect that. I want to emphasize the first code, A0021, has no comparable rates across the benchmark states that we looked at, those 10. So average benchmark states rate and the rate-only benchmark ratio are not available. So this bar graph shows the variation in benchmark ratios across the 20 NEMT codes that were under review, or are currently under review. Just as a reminder, the benchmark ratio here is defined as Colorado rate as a percentage of the average rate across the 10 benchmark states. And again, these benchmark ratios reflect NEMT rates that go into effect on July 1st. In this graph, the yellow bars represent codes that underwent both the 2% across the board rate reduction as well as a targeted rate decrease. So those 4 procedure codes in yellow. The blue bars represent codes that underwent just the 2% rate reduction. And just for visual purposes, the red dashed line highlights a benchmark ratio of 100% to show that bars that extend above that line signify codes with rates that are above the benchmark average, whereas the opposite holds true for the bars that are below on the left side. Since the last public meeting in March, we've conducted extensive outreach and additional research on NEMT commercial rates. The purpose of our outreach was to evaluate the availability and the applicability of commercial NEMT rate data for Medicaid rate benchmarking. We contacted many different entities, including commercial health plans, Medicare Advantage organizations, workers' compensation and state programs, including the Colorado Department of Labor and Employment, CDLE, and Pinnacle Assurance, one of Colorado's largest insurers for workers' compensation. We also stayed in touch with health data entities such as Civic, Seraph Health, and the Colorado Department of Public Health and Environment's Emergency Medical and Trauma Services Data Unit. The key takeaway from our outreach that I'll go over in the next few slides in more detail is that we identified potential commercial rate data sources while highlighting that there were limitations in the applicability of these data to Medicaid NEMT when it comes to rate benchmarking. This slide highlights some of our key findings from the research process for commercial rates. The first being that data availability constraints do exist. In reality, many commercial NEMT rates from the entities that we contacted are simply not available publicly or to HCPUF because they operate under a contract. Of the available data, there was often limited comparability to Medicaid NEMT. And a prime example of this was seen with Seraph Health, which provides aggregated summary level rate information, but lacks detailed nuanced definitions when it comes to the codes and services. Third, there were structural differences that we noticed in benefit design across programs and payers. Some transportation benefits are simply not comparable to Medicaid because of these design differences, and examples include managed care, as well as supplemental benefit structures like Medicare Advantage. We also identified some more targeted transportation programs, one being focused on members with behavioral health needs specifically, as well as workers' compensation program, which prioritizes quick return to work for injured workers. This slide is more of a summary, higher level overview of our outreach and findings across payer, whether they cover NEMT benefits, and whether they had any shareable NEMT rate data. As we can quickly see, a few payers like Kaiser, Colorado Access, and Denver Health do not cover NEMT benefits for their commercial customer base, and therefore do not have any available data. As I just mentioned, payers like or organizations like Civic and Seraph Health have some partial data availability via claims-based allowed amounts and commercial transparency data, but because they lack the detailed definitions for service codes, this lends itself to limited comparability with Medicaid. Medicare Advantage plans are typically not standardized benefits. Rather, select plans, like Denver Health's medical plan, linked on the left, only offer limited supplemental benefits. When we reached out to Denver Health Medical Plan to get more rate information, they were not able to share this because they work under a contract. The same goes for when we reached out to Pinnacle Assurance regarding their transportation rates. And in addition, workers' compensation generally operates under a very different utilization patterns and funding structures, making it not really a good comparator to Medicaid for benchmarking. Lastly, in our discussions with the CDPHE, Emergency Medical and Trauma Services Data Unit, we reached out to them to learn more about ambulance utilization patterns, which was some feedback that we received from the Mprrac committee in the last March meeting. Upon further discussion with CDPHE, the benefits that they cover are ambulance specific and are more suited. This analysis is more suited for the 2027 review next year, where we look at both emergency as well as non-emergency medical transportation. In the next 4 slides, I'll outline some provider feedback that the team has received both during and since the March public meeting. This first slide goes over the sharing of a single contracted transportation rate that was graciously provided to the rates review team by a transportation provider. Break this table down, there are 2 different service descriptions, wheelchair van base rate and wheelchair van mileage, across 2 different payers, Pinnacle Assurance and the VA. We want to draw attention to the wheelchair van base rate in the 3rd row of this table. The payer rate is started at $65, and this was adjusted for comparability because in the contract, its initial rate was $125, which includes 20 bundled miles with a reported base mileage rate of $3. In general, we see that Colorado Medicaid as a percent of the payer rate is below 100%, but exceeds 100% when it's compared to the average rate of the benchmark states, as we can see in the final 2 columns of this table. In general, stakeholder-provided rates offer one perspective, and we appreciate what our providers share with us always, but that these may reflect specific contracting arrangements, while multi-state benchmarking tends to lend itself to a broader basis for comparison. The second piece of provider feedback that we received relates to national NEMT utilization data. In 2020, there was federal legislation that was enacted that directed CMS to submit a report to Congress examining NEMT utilization. And this slide outlines the key findings from its preliminary report based on the years 2018 to 2021. During that time, nationally, 4 to 5% of Medicaid beneficiaries used NEMT every year, with average utilization being about 2 ride days per user per month. Use is concentrated amongst high-need populations. For example, up to 50% of members with end-stage renal disease used NEMT services. And use tends to be higher amongst rural and frontier areas compared to urban centers. These findings impose several implications for rate setting. NEMT primarily supports access for medically vulnerable populations and members. And rural geography may increase the reliance on transportation services. It's important to note that utilization data informs access considerations, which is a very important piece. However, it does not inform us on anything regarding reimbursement adequacy. And so this is one component that we must consider in the broader rate review process. The third piece of provider feedback relates to labor market differences and how that could affect NEMT benchmarking. Before I read the details aloud in this slide, I want to take a quick second to thank another provider for developing 2 different reports for us, which served as the basis for this feedback. This provider developed a wage comparison analysis, which looked at transportation wages among workers in Colorado versus Nebraska and New York, 2 of our selected benchmark states. This provider also developed a cost report impact analysis outlining key operating expenses that are required for transporting Medicaid members, as well as the financial implications that could arise from proposed rate changes. I want to emphasize that while HCPUF doesn't typically include cost provider analyses reports in our fee-for-service rate reviews, we are always deeply appreciative of the efforts that providers take in developing and sharing this information with our team. To get back to our current methodology, we select our 10 benchmark states based on service scope, demographics, and geography. And these state rates are adjusted to Colorado's current economic conditions using Mprrac cost of living indices. The provider highlighted some key considerations for transportation-specific cost structures in their reports. First, NEMT is a labor-intensive service with wage sensitivity, and general cost of living indices may not fully reflect the true nature of transportation labor markets. In addition, costs associated with the labor, insurance, compliance, and administration of these transportation services can vary across markets, and wage conditions can differ from overall cost of living patterns. The key takeaway is that geographic adjustments do help improve comparability of rates across states, but there may be some underlying transportation-specific cost drivers that are influencing benchmark interpretation. The final piece of provider feedback pertains to service equivalency and code comparability. Another transportation provider reached out to us, emphasizing that services that are classified under the same procedure or HCPCS codes could be administered differently depending on which state Medicaid program you're examining. For our current methodology, our benchmark comparisons use equivalent HCPCS procedure codes where available to support a standardized rate comparisons process. Again, we select multiple benchmark states, in this case to help reduce reliance on any single state's reimbursement structure. Key considerations on this topic include benchmarking compares relative reimbursement levels across similar service categories, but not identical program designs. And any differences in service requirements, staffing, and administrative structures can affect costs. In short, HCPCS code-based benchmarking does provide a standardized framework for interstate comparison, but also acknowledging that variation does exist across state program designs. And before moving on, I also want to thank this provider for all their hard work and efforts. And I also want to emphasize that the team looks forward to learning from and connecting from NEMT providers as we prepare for next year's review through provider engagement sessions later on in the summer.
Thanks so much, Cole. Great work. All right. As we get ready to accept public comments, I just want a reminder for everybody, we do accept public comments in the order in which they're received to be fair and equitable to everyone. So we will take those in that order. Michelle, do we have any public comments for NEMT?
Yes, we do. And I apologize right off the bat if I mispronounce names. First, we have Niketa Ricks.
Niketa? you there? You have 2 minutes.
Good morning. I'm here. I'm so sorry. Trying to unmute and get used to this. But one
Welcome.
second, please. Good morning, um, everyone. Just give me a few minutes. I just need to adjust myself here. Okay. Thank you and good morning, committee. I'm State Representative Naquita Ricks, representing House District 40, and a lot of my constituents are NEMT providers, and I'm very aware of the budget process and everything that's going on with the state and the huge deficit that we are facing. However, I really do appreciate the opportunity to provide comments today on behalf of NEMT providers across Colorado, as well as Medicaid members who rely on them to receive medically necessary care. NEMT providers already absorbed substantial cuts in the past year. Many saw their revenue drop by 50% or more. Now we're looking at a base rate reduction from $36.40 to $12.40. And that's not a trim. That's a 66% cut stacked on top of a cut providers are still trying to recover from. I just want to be clear about what's actually at stake here. NEMT is not a taxi ride. It is how Medicaid members get to dialysis, chemotherapy, behavioral health appointments. And we recently visited a dialysis center by DaVita in my area, in the Laurie area. And those members are there for like 4 hours. And these NEMT providers work around the schedules at as early as 4 a.m. in the morning, getting their dialysis patients to these centers, and these patients likewise rely on them to take them home. Many of them live in the rural areas, and that was mentioned earlier in some of the testimony that there's a lot of usage among rural areas.
We're at 2 minutes, Representative.
Yes, okay. Okay, I'm so sorry. When we cut this rate, we are not trimming transportation budget. We're cutting a healthcare access point, and this proposal doesn't really reflect what it actually costs to run a safe, compliant NEMT operation in Colorado. Labor is the biggest expense for these providers, and Colorado labor market looks a lot more like New York's than the lower cost states sometimes used by comparison. Insurance, vehicle maintenance, fuel, credentialing, and compliance are all real expenses that are Colorado costs and not national average. These providers are local small
Representative,
yes.
we're over
Okay.
time here.
Okay,
Sorry.
thank you so much. And please do what you can to reinstate more so that Coloradans can get the benefit of NEMT and these providers don't go out of business. Thank you very much.
Thank you.
Yes.
Thank you. Next, we have Liben Razine.
Oh yeah, you guys hear me?
Liben, go ahead. 2 minutes, please.
Yeah, thank you. My name is Liban. I've been a NNT and provider here in Colorado for years. And I just wanted to thank you guys for giving me the opportunity to speak. I wanted to touch on a few things, utilization data, being frauded or whatever, and you guys are unable to use it. You guys basically defaulted to the 10-state comparison. And I did a national NEMT rate comparison. And Colorado's $36.40 reimbursement rate actually falls in the range of mid-range, actually, when it comes to the nationwide comparison. And now this $12.40 actually dropped us down to the bottom. In this analysis, obviously, it includes brokered rates as well. So it is a diverse T rate in there. Just states that do Medicaid reimbursement. Yeah, and I also wanted to touch on the survey that I found. This survey, she mentions, so the survey is the NEMT AC 2026 rate, and it's a nationwide survey was taken. And the survey found that 70% of NEMT providers are calling for rates be that are basically barely sustainable. 60% expect rural provider to exit, which we're already experiencing here in Colorado. One of the biggest rural area providers are basically forfeiting their transportation services. Yeah, I also wanted to mention that the code.
Leave in, we're at 2 minutes. If you can wrap up, please.
Yeah, no problem. Yeah, I mean, I just wanted to bring those to the table. Appreciate you guys for giving me that too. Thank you.
Thank you.
Thank you very much.
We have Henny Burhane. I don't see this person listed on the attendees at the moment.
I'll just take this moment to remind folks, if there are repeated comments, please reference those as reiterating or reinforcing previous comments. There's no need to say exactly what someone else has said, if at all possible. That allows more people to speak today. Go ahead, Michelle.
Okay, Henny, last chance for Henny. Okay. All right, next we have, and I'm sorry, I will mispronounce this, Emmanuel Wolde-Gorgeous.
Emmanuel?
Yes, I'm here.
Please, 2 minutes.
Good morning, members of the committee. My name's Emmanuel Wolde-Gorgeous, and I appreciate the opportunity to speak today. I just want to focus on one question today. Why are Colorado NEMT providers being asked to absorb two of the largest reimbursement reductions in the entire Medicaid system? 53% and now 66% within a single year. In July of 25, providers absorbed a 53% reduction in mileage reimbursement. That reduction fundamentally changed the economics of operating an NEMT business. Providers responded by cutting overhead, delaying vehicle purchases, reducing administrative costs, and finding every possible efficiency just to keep serving Medicaid members. Now, less than a year later, we are facing a second reduction, this time 66% cut to the A0120 base rate, dropping it from $36.40 to $12.40. These are not routine adjustments. These are extraordinary reductions imposed on the same provider community in rapid succession. If Medicaid programs overall are experiencing reductions of around 2%, why is NEMT being asked to absorb reductions of 53% and then now 66%? No other healthcare sector could withstand cuts of this magnitude without severe consequences. And these cuts are cumulative. Providers have already spent the past year trying to survive the first reduction, depleting reserves, postponing vehicle replacements, delaying technology investments, reducing staff, accepting drastically lower margins, simply to maintain access to Medicaid members. There is a point where additional reductions don't create efficiency. They make continued operations financially impossible. Our request is simple. Please evaluate the total financial impact of these consecutive reductions, not just for the proposed base rate cut in isolation, and please consider whether NEMT providers are being asked to shoulder a disproportionate share of Medicaid costs compared with other provider groups. We are not asking to be exempt from fiscal responsibility here. We're asking for fairness, proportionality, and a reimbursement methodology that is equitable, sustainable, and recognizes the essential role NEMT plays in Colorado's Medicaid program. I thank you, members of the committee, for giving me the opportunity to speak, and ask if you please consider our ask here today.
Thank you, Emmanuel.
Thank you, Emmanuel. Next, we have Yonatan Sabat.
Yona?
Yep. Good morning.
Welcome.
Are we good? Can I?
Yeah, 2 minutes, please.
Thank you. Good morning, Chair and members of the committee. My name is Jonathan Sabat. I wanted to address one important message today. NEMT is not simply a transportation. It is an essential healthcare infrastructure. Every day, Colorado NEMT providers transport Medicaid members to dialysis, chemotherapy and radiation, behavioral science treatment, substance use disorder treatment, primary care, and specialist appointments. Without NEMT, there's no access to healthcare. When patients miss these appointments, the consequences are often emergency room visits, hospitalization, additional hospitalization, psychiatric crisis, high long-term Medicaid costs. The cost of providing transportation is far less than the cost of treating preventable medical complications. Behind every reimbursement rate is a real person, a senior citizen trying to reach dialysis, a mother receiving cancer treatment, a veteran attending behavioral health counseling, a child traveling to a specialist care. These individuals are not asking for luxury transportation. They are simply asking for access to medically necessary healthcare. I respectfully ask the committee to reconsider the proposed reimbursement reduction and recognize that investing in sustainable NEMT provider network is an investment in preventing healthcare, better patient outcome, and lower long-term Medicaid costs. Thank you for your time.
Thank you, Jonathan.
Thank you. Next, we have Takesha Trejo Neves.
Lakeisha?
Yes, hello.
Takesha, welcome. 2 minutes, please.
Hi, everybody. Good morning. My name is Takesha, and I'm a NEMT driver here in Colorado. I'm also a proud mother of four. For me, this isn't just about reimbursement rates. It's about whether I'll be able to provide for my family while continuing to help some of Colorado's most vulnerable Medicaid members to get the medical care that they depend on. And honestly, I truly love what I do because I know I'm making a difference in people's lives. But these reimbursement rates, the reductions moving forward for my family's future becomes uncertain. I would have to work many more hours just to try to earn what I earn today. That means less time with my children and even more money spent on childcare, if we can even find it. If my company can't survive these reductions and I lose my job, my family could lose the stability we worked so hard to build. Instead of working and paying our taxes and supporting ourselves, I may have to rely on state assistance just to keep food on the table, pay our bills, keep a roof over our heads, and provide health care for my children. My family would go from supporting ourselves to needing help from the very system we're working so hard to support every single day. And honestly, that's not the future I want for my family. And as a mom, that is heartbreaking. My children could also lose opportunities that many families take for granted. Summer activities, sports, and other programs that help them grow and simply enjoy being kids may no longer be something that we can afford. No parent wants to look at their child and say, I'm sorry, we just can't do it this year. I also want to speak for the Medicaid members I transport every day. Many of my clients have ridden with me for years. They know me, they trust me, and I know their individual needs. For many of them, having a familiar driver reduces anxiety, builds trust, and helps them continue receiving the medical care that they depend on. So
We're at 2 minutes now.
I respectfully ask you
Have to wrap up.
to reconsider this and the impact it has on families like mine and Medicaid members. So thank you for your consideration.
Thank you, Takesha.
Bye.
Thank you. Next, we have Danny Bennett.
Welcome, Danny.
Good morning.
2 minutes.
Good morning,
please.
Chair, member of the committee. My name is Danny Bennett. Thank you for allowing me to speak today. I'm here to address an issue that goes far beyond NEMT reimbursement rates. And I wanted to just touch base on its impact on the economy in Colorado overall. This is about Colorado small businesses. It's about Colorado's workers. It's about Colorado taxpayers and long-term financial consequences of reducing reimbursement below sustainable levels. Colorado's NEMT providers are overwhelmingly locally owned small businesses. We're not large corporations to be able to handle the amount of stress within the short period of time that is being expected for us to withstand. We're family-owned, community-based companies that have spent years serving Medicaid members, healthcare facilities, dialysis centers, and so on and so forth that everybody mentioned already. And according to the U.S. Small Business Administration, small businesses are about 99% of Colorado businesses in general. And we employ about roughly 1.2 million Coloradians. And NEMT providers are part of that economy. And taking that away or reducing it significantly would mean having to close doors, which then is going to impact Colorado business in general. Our businesses also support other Colorado businesses. We buy fuel, tires, vehicles, repairs, insurance, technology, office services, and other local vendors. Every dollar that's being spent on NEMT, it also is supporting jobs, families, small businesses, and tax revenue. And CMS has made it clear that transportation is essential to Medicaid access because healthcare coverage means nothing without actually being able to physically get to the care. If reimbursements fall below sustainable level, providers will be forced to make painful choices. They may have to reduce hiring, cut employee hours, delay vehicle replacements, and so on and so forth, which then workers may lose their job, local vendors may lose their business, Colorado may collect less taxes. And the greatest concern isn't this. The greatest concern that I have is what Takesha just brought up. It's right now, the people who are currently contributing to Colorado's economy may become the ones that are going to be needing the state's assistance.
We're at 2 minutes.
Okay, I'll wrap up right here. We're instead of what we're doing is actually taking a risk on converting taxpayers into recipients of the state assistance. And my ask is that as the committee considers not only to relook at this, but also investing or for them to understand investing in NEMT means that it's investing in our communities. Thank you so much.
Thank you.
Okay, next is Aaron Gourmet.
Welcome, Aaron.
Good,
Please.
good morning, everyone, chair and member of the committee. My name is Aaron Gourmet, and I appreciate the opportunity to speak today. I would like to focus on one question. Can Colorado NEMT providers continue to operate under the proposed reimbursement structure? Based on the financial analysis that have been submitted, I have submitted to this committee, the answer is no. There is a common misconception that because transportation companies own vehicles, reducing reimbursement simply reduces profit. That is not the reality of operating on NEMT business. NEMT providers operate under extensive federal and state requirements. Every day before we transport our first Medicaid member, we have already incurred significant operating expenses. I'm going to mention some of those. Those expenses include qualified driver wages, payroll taxes, workers' compensation, insurance, commercial automobile insurance, general liability insurance, vehicle specialists, compliance personnel, credentials, software system, office rent, utilities, internet, phones, employee training, and ongoing regulatory compliances. Those expenses remain virtually unchanged regardless of reimbursement. Over the past several months, financial information from multiple Colorado NEMT providers has been reviewed to better understand the actual cost of delivering these services. The purpose was not to represent our company, but to determine whether proposed reimbursement reflects the financial reality faced by providers throughout Colorado. The findings were consistent. Under the current reimbursement structure, providers generally operate on average modest margin after covering all operating expenses. Under the current reimbursement structure, providers generally, however, reducing the A120 base reimbursement from $36.40 to $12.40 dramatically changes that equation.
We're at 2 minutes, Aaron.
All right. So just to summarize, what I want to say is we're going to be in the negative based on that. And if I can just say one thing is yellow cab rate is $4.50 per mile. So it's going to be a lot, we have a lot of laws to follow versus they do. Just want to mention that as well. Thank you.
Thank you, Aaron.
Okay, next, Allison Parasay.
Allison, welcome.
Hi, my name's Allison Parsi. I work over at Complete Recovery Systems. Thank you guys for letting me speak today. So every day we see people who are trying their hardest to rebuild their lives, and the only way they can take the next step is if someone gets them to that door. Companies like Danny's MedRide doesn't just provide rides. They provide access to treatment, counseling, medication, stability, and hope. They show up early, they show up late, they show up in bad weather, and they show up when no one else will because they know what's at stake. At Complete Recovery Systems, we see firsthand how essential reliable transportation is for the people we serve. When someone misses a ride, they don't just miss an appointment, they miss progress. They miss connection, they miss a chance to stay on track. And for many of our clients, NEMT is the only way they can get to the services that keep them alive and moving forward. That's why these significant rate cuts are so dangerous. They don't just threaten companies, they threaten people. They threaten veterans, seniors, individuals in recovery, and anyone who depends on these rides to access care. If NEMT providers can't survive, people will be stranded. And when people are stranded, recovery becomes impossible. Danny's MedRide goes above and beyond every single day. They serve with heart, with compassion, and with commitment that cannot be replaced. Cutting their funding means cutting off the very people who need help the most. We're asking for one simple thing: protect the transportation that protects the people. Because when you support NEMT providers like Danny's MedRide, they're not supporting a business. You're supporting recovery, dignity, and access to life-saving care. Thank you guys for letting me speak today.
Thanks, Allison.
Thank you, Allison. Next is Emily Bedwell.
Welcome, Emily.
I don't see her on the participant list. So we will move on to the next person, Ross Peterson.
Welcome, Ross.
Hi, everybody. Thank you for giving me an opportunity to speak briefly. I am an NEMT consultant with 20 years of experience working with health plans in rate setting and NEMT program policy design. I'm also an operator of a wheelchair accessible transportation service that I have recently joined forces with Sunshine Rides to operate here in Colorado. Some of you might be wondering why you're hearing such a difference between what the providers in this room are saying and what the analysts are saying. The analysts are saying Colorado's benchmark is below, or Colorado's rates are in line with the benchmark rates. I'm here to tell you that is inaccurate. The analysis is misleading. The benchmarks that we're looking at are from states that operate a structurally different program than Colorado. Colorado's program is entirely fee-for-service. Many of the benchmark states we're comparing against have a managed care component to their Medicaid program, and the rates paid under those managed care elements are not showing up in the benchmarks. Because of that, we're oversampling for fee-for-service data, and we're not looking at the negotiated market-based rates that managed care organizations pay. So I want to be on the record with this group showing that the 10-state comparison is not accurate. And that is why you hear providers in this room saying that these rates will put them out of business. The Joint Budget Committee, I believe, overcorrected because there was a previous rate decision made on inaccurate benchmarking that used ambulance rates, resulting in overpayment in certain circumstances that led to fraud, that led to problems in the program. And now we are overcorrecting for that problem, but committing the same mistake. We need to use accurate data or allow the market to make these decisions, or we will continue to have inaccurate rates. But this time,
2 minutes, Ross.
These low rates will result in providers exiting the market. Thank you for my time.
Thank you, Ross.
Next, we have Zoe Kerr.
Sorry.
Zoe, welcome.
Yes,
2
I'm here.
minutes.
Can you hear me now?
Yes, please.
Yeah, I guess I'm not prepared with any notes, but I'll just say that right out of my mind. The rates that are set by the states is completely out of the border, and we do have a lot of expenses. Just looking at my company by itself, over $6,000 is what I pay for insurance, for example, for commercial insurance, and I'm not going to be able to do that come July. I may have to exit a lot of vehicles, just manage to see how many vehicles I'm able to handle. So I don't know how or what kind of regulations or research they have done to come up with this amount. And I just wanted to make sure to let you guys know this definitely will put me in bankrupt, and I'm starting over. And a lot of people that have started business or job with me, with family-owned people, they have kids, they have 2, 3 family members, they will be out of business, which they'll have to find another job. And again, I just want the committee to relook at this rate cut. Thank you.
Thank you, Zoe.
Thank you. Chris Erickson.
Welcome, Chris.
Hi, thank you all for giving me the time to speak. My name is Chris Erickson. I'm the Director of Operations for Silver Linings Recovery. I don't work for an EMT company at all. We do work hand in hand with some that bring our clients here. Okay, these rates that are proposed to change on July 1st are going to put a lot of these companies out of business, including the ones that bring our clients here. So the thing is that if our clients don't get here, it could mean the difference between life and death. This is a fact. Our clients are in recovery from opioid addiction, alcohol addiction. With the fentanyl crisis the way it is, we all know that it's extremely out of control. We're fighting a losing battle against it. And some of these clients that are coming here are able to receive the services that they need to become productive members of society. If they're not able to get to our doors, what's to stop them from, hey, check it out, I can't get there today. I'm just going to go get high. If they go get high, and it's fentanyl in particular, that one time of use could be the death of them. It could kill them. It's a very, very, very much needed service. And a lot of these people that are out here are houseless. They don't have a way to get anywhere besides maybe bus transportation. And a lot of the times they can't afford that. I'm just asking that a little bit be reconsidered to help the NEMT to try to get people to our doors, where they can get the help that they need. Thank you for the time.
Thank you, Chris.
Thank you. And lastly, we have Amanda Schoniger.
Welcome, Amanda.
Hi, everybody. Thanks for letting me talk today. My name is Amanda Schoniger. Hold on one second. I want to address the current Medicaid transportation rate structure as it is a real world impact on providers and member access. Non-emergency medical transportation is not just a mileage-based service. It's a regulated, labor-intensive healthcare access system. Every trip requires trained drivers, dispatch coordination, vehicle maintenance, compliance checks, and strict Medicaid documentation. These fixed costs that exist before a vehicle ever moves. At the same time, providers are facing rising costs in fuel, wages, insurance, and compliance, while reimbursement rates have not kept pace. In Colorado, now recognized as one of the most expensive states to live in and operate a business, those pressures are even more severe. For context, the national average ambulatory load fee ranges from $25 to $45, reflecting the base cost in initiating a trip before mileage is applied. When local reimbursement falls below that range, providers are forced to absorb the differences or reduce participation. When the rates fall below the true cost of service, the outcome is predictable. Fewer providers, longer wait times, and reduced access for Medicaid members, especially in rural and underserved areas. Sustainable rates are not about increasing profit, they are about preserving access. Without adequate reimbursement, the network weakens and members lose reliable access to essential care like dialysis, behavioral health, and primary care. We're asking for a reimbursement structure that reflects actual costs, aligns with national benchmarks, and ensures long-term network stability. Thank you for my time.
Thank you.
And that concludes the public comments.
Thanks, Michelle. Members, open for comments, but we're certainly looking for recommendations on both those codes with the benchmark ratios or the fee for service, if any.
I'll start. First of all, I want to thank all the public commenters for the feedback. I think we hear you on the importance of access to care for this service. I've seen patients benefit from this service, so definitely understand the importance and the impact of the magnitude of cuts. One thing I wanted to just clarify for everyone, and Kevin or Michelle or Brian, just to help me with this, that the work that Mprrac does is recommending rates for next year. So I think my understanding is there is a rate cut that's going into effect in July 2026. The work that we do is for recommending for rates for July 2027. a year from now. So anything we were to recommend is not going to impact July 2026 and would impact July 2027. So I just want to like start with that as a point of clarity. And if there are real like emergent access issues, like what is the right route for stakeholders to kind of engage in? That's more like a HICPUF question.
First off, yes, you are absolutely correct. What we're doing right now is just for everyone's benefit. The the committee is considering recommendations that will then come to the department. We will put those recommendations and our own recommendations into a report that goes to the Joint Budget Committee on November 1st, along with the governor's budget. Well, not that those two things are attached, but just that they happen at the same time. And although they do inform each other. And then that will be considered by the Joint Budget Committee that then creates the long bill that goes through the legislature and then gets passed and then, or amended and then passed and then gets signed by the governor in usually April, May timeframe and becomes effective for July of next year. And as far as what people can do at the moment, we have a lot of people reaching out to us. It sort of depends on exactly what avenue they're trying to take. People always have access to their elected representatives. They always have access to us, and we will escalate appropriately through our chain of command. So it really just depends on the exact situation for this. I believe that they are already reaching out to elected representatives, and we've already been passing along all the information that we get all the way up through our leadership within the department and along to the governor's office. So I'm not sure if there's, like, I don't know of any other avenue in addition to what is already being done.
Sounds good. Thank you.
Megan?
Yeah, so as we're sort of thinking about what our recommendations might be for this term, I'm just thinking that the impact of adjusting, sort of a percentage to benchmark for any given code is maybe not equal code by code. So those that are most frequently used or most impactful, I think that would be helpful information to know from our, like, the service providers, if there are certain codes that would have a bigger impact if there were a rate adjustment. I think the graph that was shared about, where these different codes fell with respect to the benchmark and which had the larger proportional decrease.
Can we go to that bar chart?
Was helpful. But again, if we were to make a recommendation similar to what we've made in the past of trying to raise codes that were below 80% up to 80%, and those, perhaps those that are much, like, that are outliers down further, what would that impact really look like? So a code that's up at 180% of benchmark, is that a particularly critical and frequently used code?
Nicole.
Hi. So I'm trying to be an observer since this is my first meeting, and just really get a understanding of the lay of the land. One of the questions I do have, though, it seems that, and disclosure, I'm a rural practitioner, but I don't see much in the way of understanding how this impacts rural practices and the utilization in terms of rural practices. And if we've done an analysis as well, most of the people that are speaking today and the wonderful commenters have said, have talked about, like, their experiences, but I'm wondering if we have any information on access in rural and urban environments. and if that has any impact on the way that these rates are utilized.
Lingling?
Thank you for your feedback. Actually, because this is a rate only out of cycle review, we don't include any utilization data, so we didn't have access to care analysis for this year. But definitely we will have it for next year, the full review. And in addition, I want to mention on this chart, the 4 bar, the yellow color is they have the targeted rate reduction. Like the huge one. All the rest, they have the across the board reduction. That means this 4 code, especially the A0120, A0122, that 2 pickup fee has the biggest reduction.
And what was the reason for those 4 codes in particular having the targeted reduction? Or was it because of the frequency of use or just the relative expense?
I want to pull Annex. He's the policy manager. Annex, can you please chime in?
Hi, Ling Ling. I'm so sorry. My attention was elsewhere. Can the question please be repeated?
I'm trying to understand why the 4 specific codes got the larger targeted reduction. Why were those codes in particular identified as an issue?
And I agree with what Megan said. And then can you just explain the full history of the last like 12 to 18 months to us? Like it sounds like there was a cut like a year ago. My understanding is that was like the wheelchair code, and then this code that's coming about to be in place next week would be the kind of ambulatory code. But can you just like explain the history and the why to us?
Sure, I'd be happy to. Thank you. And by means of introducing myself, my name is Alex Weichselbaum. I am the primary and ancillary care section manager for the department, and my team oversees the NEMT benefit. I'll try to tackle this in reverse chronology. So, over the past, I don't know, 8 months really since the beginning of the legislative session, the Joint Budget Committee, of course, faced the difficult decisions of balancing the state's budget. And one place that the committee identified an opportunity to balance the budget was through these 4 codes for the NEMT program. There was a series of discussions between the JBC and the department, the information of which is publicly available on the JBC's website. And ultimately, it was the Joint Budget Committee that landed on the rates for these codes that are being reduced for the NEMT program. Prior to that, in the prior legislative cycle, basically the same process resulted in the mileage reimbursement code going down from, it was like $6.45 to $3 per unit of service. Is there any ground I haven't covered or anything further I can help explain?
I guess a specific question I have, because of all the codes on this graph, the one that looks like an issue to me is the one that is S0215, that's at 181% of the benchmark. So I'm specifically trying to understand, what is that code? What does that code mean to service providers, so that if we were to, say, make what has been a fairly typical recommendation to bring codes below 80% of benchmark up to 80% and bring outliers down, like say bring that down to 140%, what would that mean? Is that one of the particularly critical codes to these service providers that would represent like a really significant impact? And so I'm curious what that specific code is.
Sure. And that's a great question. So Let me start by explaining that trips for NEMT are reimbursed to providers using two codes. There is always a pickup fee code, and there is always a mileage reimbursement code. So for a typical ambulatory NEMT ride using a sedan, each leg of the trip would be billed with 1 unit of A0120, that's the pickup fee, and however many units of service correspond to the number of miles traveled with the passenger. The mileage reimbursement code is S0215. So the July 1st, 2026 rate will be, I believe, $2.74 per unit of service, which means $2.74 per mile traveled. This is on top of the base pickup fee, which is A0120. So every time the Medicaid member enters the vehicle for the pickup, the provider can bill 1 unit of service for that pickup fee. So together, these two rates create the combination of payment. Now, what I really need the committee to understand here is that there is a formula that drives the reimbursement for trips. It is a formula that examines the amount of money that comes from each component of the trip based on how many miles the trip is composed of. So for short distance trips, such as trips that are maybe only 2 or 3 miles, the majority of the payment is going to come from the pickup fee. For long distance trips, the majority of the payment will come from the mileage reimbursement for S0215. S0215 in particular is inclusive of many, many costs that are associated with providing NEMT.
Thanks, Alex.
I do have a quick question too, and this is based on personal experience. Were there any changes that were made to the way that these services can be accessed, in addition to the changes in the cuts to the fees, from the Joint Budget Commission?
Thank you for that question. And the answer is no, but the background context is that the department is currently implementing a statewide broker for NEMT services. We're hoping that by sometime later this year into next year, that there will be a third-party entity that is contracted by the department that serves as the go-between when a member needs a trip and finding the trip to be scheduled through an NEMT provider. Presently, the broker is only serving the 9 Metro County area, which means that if a member lives in the 9 Metro County area, such as Denver, they would contact the broker company would find availability with a transportation provider in the network, and they would schedule the ride with the available provider for the member. The member does not need to go searching for their own transportation provider. For the 55 other counties outside of the broker network, presently there is no broker. The member needs to find the provider on their own. However, in both situations and for the entire state, all NEMT providers receive the exact same payment rates. The function of the NEMT broker in the middle does not affect the payment rate to the NEMT provider.
Thanks, Alex.
So, couple of follow-up questions. So, just to clarify, so new broker is coming this year, but that does not impact our work at all. And then I guess, Alex, secondly, can you just help us kind of juxtapose the benchmarking data here versus the stakeholder feedback, where it sounds like there are these cuts coming. This slide here shows post-cut, which for some of these codes still shows above the benchmark, yet, providers are, it sounds very dire from a reimbursement perspective. So I'm just struggling to square that.
Sure, you bet. So yes, correct that the incoming transportation broker will not affect what we were talking about here. Without without editorializing, as objectively as I can provide here, every NEMT provider is going to have their own costs associated with running their business. Large providers with many, many vehicles in their fleet have different ways and different costs associated with running their business than small providers with maybe 1, 2, or 3 vehicles in the fleet. Another sort of wild card in this mix is that the cost of providing transportation is dependent on so many different variables for the provider. How they finance their vehicles, what sort of insurance they could get, what they choose to pay their drivers, the where they're buying their fuel even could be a factor in this. And the most difficult thing to peg down is that the efficiency of the route that any given provider has will also greatly affect their costs and their profits. If the provider is operating very inefficiently and incurring unnecessary deadhead miles, those are miles in which there is no passenger in the vehicle, their costs will be higher than a more efficient operation in which most of the time there is a passenger in the vehicle. And so what I heard today here, the sort of difference between the data being presented by the research here and all the testimony we've received is sort of testimony from individual costs from providers and a bigger picture look at how Medicaid payments stack up to other states, which is essentially an average of all the payments. Whereas providers are coming to the table with insight into perhaps the way their own business functions. But unless we talked about this before, I'm not sure that profit margins have been something that has been illuminated yet.
Christopher?
I just had a clarification question. So I understand about the new broker program that's coming up starting next week, and it's going to be phased in over the next few months. Is there also a rate change that's already predestined that's happening at the same time as this broker program?
Yes. So presently, as of today, the reimbursement rate for the pickup fee for normal NEMT, so A0120, is about $36. Starting July 1st, because of the Joint Budget Committee and the need to balance the state's budget, that pickup fee will be reduced to about $12. The mileage reimbursement for S0215 will go down from $3 a mile to $2.74 per mile.
Thanks, Alex.
And we're doing this review. This is an out of cycle review that we're currently doing, correct? Did I miss when is the scheduled cycle review for this service? Do we know?
Next year.
Next year? Okay. So we're going to come up on this again next year.
Yep.
Okay. I just want to make sure I understood that there are things that are related and things that aren't related, but then at the end of the day, they are all related.
Yeah, and I guess hearing all that, if we want to start with like recommendations, my recommendation would probably be just to keep things the same. And we'll revisit this next year and the system will sort of see what the impacts of the changes that are happening right now. Because again, other than like looking at what we're seeing right now, we have one significant like high outlier. There may be a couple that are low outliers, but looking at what those codes are, they don't seem like they're maybe codes that are used as frequently or as are going to be as impactful. And so yeah, I'm reluctant to recommend a more significant change.
I think another way to do it, Megan, would be to bring anything under 100% of the benchmark up to 100% of the benchmark. This is a Medicaid benchmark service to other states. So these blue ones on the left of this slide that are below, we bring them up. But the ones that are already at 100 or above 100 or substantially above 100 are harder to raise further. And I think that would be pretty inconsistent with how we've handled things previously.
Yeah, I mean, I tend to agree with that. I think just in if we're considering in light of the current situation, do we feel like there's a need to bring up these lower codes? And like, to what degree are those the ones that are driving the challenge, as opposed to the codes that we see on the higher end, or particularly those that are highlighted in the yellow, that seem like they may be the more frequently used codes.
I agree. I think my perspective is trying to do something in the face of what sounds like very dire provider feedback, that bringing the low up would be responding to that feedback and doing something. Um, though I agree, I don't know that it will fully address the issue that we hear, which is more on the right-hand side of this slide, which I think is I can't remember a time when we've been at 180% of a benchmark or 140% of a benchmark and increased. I like, let me know if I'm misremembering, but I can't remember that ever. And so I think the most consistent thing we would do with how we've treated similar situations before is to raise the ones below 100% up to 100%, and then encourage the stakeholders to engage with the JBC, with HICPUF, and with their legislators to help ensure that these ones that do that something can be done there. So I will try and solidify that into a recommendation to take anything below 100% of the benchmark to 100% of the benchmark, anything at or above 100% of the benchmark to leave stable.
Members?
I guess since my concern is if we're being asked to consider the budget constraints or kind of be aware of that too. If I just don't know enough, if these, like Megan, what you said, if these are the rates that are below the benchmark are really pushing where the need or the driven need and the concerns that the stakeholders have, if that's really pushing that concern. So I'd be reticent to say, let's push those up to 100% of the benchmark if we're being asked to be really considerate of and selective of the changes that we're being asked to make. It's just my opinion.
Yeah, I mean, and I think that, if we're being asked to sort of maybe give a double recommendation or some conditional recommendation, like, I would be very interested in seeing what the data looks like if we were to make a recommendation more consistent with what we might have made in the past, which is Ian's recommendation. And then I would feel comfortable doing that with the caveat that we'd also like to see how that contrasts to things just staying as it will take effect in July.
So, Bill, I like that, and building off of that, maybe we go with this two recommendation idea of like the ideal, kind of what we would have done before, would be what I said, raise below 100% up to 100%. The second would be what you've been saying, Megan, which I'll call it the pragmatic, or help me think of a good word. I don't know. Pragmatic is the first thing that comes to mind, and that would be to leave rates as they are and not raise the lower. That's what you're saying, right?
That's correct.
Okay. How do committee members feel about that?
I'm good with that.
I would go with that as well. I think we're in danger of having to deal with a fait accompli that's happening next week, whether we can do anything about it or not. We're going to review it again next year. We'll have a better idea from HICPUF of if there's access issues. And we'll have more information to make better adjustments to address some of these more serious provider concerns, I would think.
I think the information we also need might relate to utilization.
Yeah.
Backs off what Megan was saying. Like if we go the benchmark route, what are we looking at in terms of utilization being impacting that?
Okay. Any other member comments?
I agree with the double recommendation also.
Okay. Just in the interest of time, let's keep going. So I think we have the dual recommendation of the ideal, bring under 100% up to 100%, keep anything 100 or above the same, and the pragmatic recommendation be to leave rates as they are. And I think we have to do, that is the number 1 on this slide, and we have to do the number 2 as well. Is that right here? Kevin, did you want to?
Yeah. Sorry, that was my hand is up for something else that I just want to get to before we're completely done with this topic.
Okay.
But yes, you are correct.
Do members have any thoughts on number 2?
Our approach to that previously was to recommend an increase sort of based on the inflation rate.
Right.
I don't know where that's at right now, but previously I think it was around 3%. So I think
3% is, I think we're still around 3%. So I think that would be consistent. Yes.
Yeah. So I think that's what I would suggest.
Are members comfortable with what Megan is suggesting of for non-benchmark codes of 3% inflation adjustment?
I am. Yes.
Okay. Any dissenters? Okay. Let's go with that for number 2. And yeah, Kevin, feel free to jump in.
Yeah, I just wanted to address something that I've seen in the Q&As, chats and stuff. I have not been able to follow the conversation and everything, but I did at least pick this out a couple of times. If we could go back to the slide with the rates on it. Okay, so I just want to make absolutely clear here that when we're talking about the 1240 rate for A0100 and A0120, that was the targeted decrease. There was an additional budget action of a 2% reduction across the board for everything. So the end rate as of July 1st is 1215. And likewise for A0130 and, or sorry, not 130, S0209 and S0215, the end rate is 274, not $3. So all of our analysis here that we've been presenting is based on that final rate, not the like interim targeted before the additional 2%. But I just want to make that absolutely clear to everyone because it does seem that there's some confusion in the in various different comments that I've seen.
Thanks, Kevin. Ian, we had talked in November, just to make clear, people see the language of our recommendation. Did we want, and we'd asked those folks to make the proposal in written form. Was that working?
Yes. Do you want me to type it in, or does someone from the department want to type it in? I forget who types it in.
I think we said that members would type it in so we wouldn't misquote you.
Okay, then give me 30 seconds to type it in.
Yeah, I think we've got the votes ready. I just wanted to make sure it was in the record that and reflected the 3% increase on the fee for service. Okay, I think we're ready to move forward to the next service. So we have maternity services, 4 categories to work through. Kevin, your hand's up again. Oh, down. Okay, thank you.
All right, I was just still up from last time.
Yep. Okay, there's the language. Thanks, Ian. If there are if that changes your mind, members, take a look at that. Otherwise, we'll move forward with the previous agreement. Maternity services. So general maternity. Looking at about 24 million in expenditures for 18,000 members. That's a decrease in 3%. And we have 1,300 plus providers, and that's an increase of 2%. And the overall benchmark rate comparison is 90.9% of the benchmark. Again, for general maternity, there's 57 codes, 56 have benchmarks. And among those with combinations with the benchmark, 98% use Medicare, 1% uses other states. The benchmark range is a bit of a spread, 15% to 143, but 95 fall within that 80 to 100 range that we've generally targeted. And those account for 99% of the utilization. The top codes by utilization, you can see fetal non-stress tests, obstetrical care, cesarean deliver only, etc. Southeast Colorado, there was an investigation here. Where do members in Southeast Colorado go for certain maternity and surgery services? Residential counties included those listed, their maternity service labor delivery codes, and I'm sorry, I'm going to have to blow up this chart to get the percentages right. Maternity service county as the same would be 11. A surgery service county would be almost 30% as the same as our residential. Otherwise, people are looking at Pueblo and Alamosa for maternity services largely, and El Paso and Pueblo for surgery services. General maternity, the 59899 HD critical code above 140% of the freestanding birth centers. This is new. These are licensed healthcare facilities, not a hospital or attached to a hospital, where care providers, including certified nurse midwives and physicians, provide family-centered, culturally competent, and comprehensive prenatal care. Postpartum, labor delivery, postpartum care to healthy, low-risk pregnant members and their newborns. Comparing the birthing center to other states, we're at 143.6 of the benchmark. This code has received a targeted increase in 2020. Since then, it has only received across-the-board adjustments. Your bubble chart has that up in the far upper right corner. And the summary here for general maternity, that provider participation rate is stable, 80 to 81%. Urban and rural panel remained stable over those 3 years. Penetration rate increased in 54 out of 64 counties. And the drive time map shows 88% within 30 minutes of a general maternity provider. And the PUPY expenditures were less than those of other payers, but remained stable over 3 years. Are there public comments?
Not for this category.
Members, what do you think?
I mean, I think this looks right where it ought to be. I don't see any need for recommending changes.
I have a similar recommendation or reaction. This is primarily a Medicare benchmark service. Like 98% were for Medicare. We've historically looked at 80 to 100% of Medicare as being what we consider a reasonable benchmark for Colorado. And it looks like we are basically right there based off of slide 36. So I think it is consistent with just staying put. Does anyone on the committee feel differently? Okay, and then for number 2, is the committee comfortable with doing the same approach that we did on any benchmark codes to be at a 3% inflation adjustment?
I did that.
Yeah, I can agree with that.
Yeah, I concur.
Okay. So to summarize, we will not do a dual recommendation in number 1. We will just recommend codes stay the same for number 1, and for number 2, a 3% inflation adjustment. I'll put that in the chat right now, and then yeah, I think we can keep going.
Thanks, Ian. All right, doula and lactation support services. This has been updated since last time. So total adjusted expenditures last fiscal that we know, 594K, so about a little over $500,000, serving 737 members with 72 active providers. Repricing against other states as a benchmark source. And those are listed with the asterisk below, Missouri, Nevada, and we've removed Minnesota and California there. So we're benchmarking 125% against other states. And then for TRICARE, this was added as a dual benchmark for doula services. So there's only 1 year of data here as a reminder on doula services. Insufficient data for lactation support services since it was a new benefit and there's been unstable trends. But for both, we're looking at 125 against other states or 86% against TRICARE. Just an update here on the benchmark. The intent is to leverage a community-based doula model that improves outcomes for pregnant people through continuous labor support with wraparound pre and postnatal care. The code T1033 billed to reimburse for labor and delivery support for 1 member. Rates for this were informed through extensive stakeholder engagement process, including meetings and incorporation of feedback from providers, advocates, and other parties. The rates were set to support realization of the benefits of the program. There is large variability in reimbursement policies across states. So, for example, Missouri and Nevada were added for a more comprehensive comparison. Minnesota's rate, because it didn't align with our code, and the same is true for California. TRICARE was added as a dual benchmark. Again, adjusted rate overall 125.8%. but against TRICARE, just 86%. When we look at the codes, 20 total procedure code modifications, or modifier combinations, the 2 doula procedure codes listed there, 1 and 2 in the chart, and 18 lactation support services have different combinations. These do not have sufficient utilization, the lactation, and the lactation procedure code and modifier combinations can be split into individual codes U1 and group codes U2. The other modifiers are time units and don't impact the benchmark. So here you can see rows 1 and 2, you get that 138 and 132 for doula, and lactation, you're at 77 or 82% on that other combination. These just represent 1 fiscal year, and since those lactation services began in 24, and there's just not sufficient data. The provider participation was 95.9%. 25 counties utilized doula services, with the highest in Denver. And the drive time map shows that 84% of members live within 30 minutes of a provider. Public comments?
Yes, we do have one from Kara Poland.
Hi, good morning, committee
Kara,
members.
2 minutes, please. Go ahead.
Sure. Thank you for the opportunity for speaking today. My name is Tara Poland. I'm the maternal program coordinator in Colorado Medicaid provider at LE Nutrition. I'm also a registered dietitian and international board certified lactation consultant, and with experience in working with moms and infants in hospital settings and also community settings. I'm here today in support of maintaining reimbursement rates for lactation support services. As we know, breastfeeding supports substantial health benefits for infants and mothers, including the decreased risk of obesity, diabetes, asthma, SIDS, and certain cancers. And it's recommended by the Academy of Pediatrics to exclusively breastfeed for the first 6 months and continue for 2 years or longer. And while it's natural, it's a learned skill that requires ongoing support. And despite these benefits, 35% of Colorado infants are exclusively breastfed at 6 months, and that's below the Healthy People 2030 target, and rates continue to decline throughout the first year of life. Access to lactation support is especially critical during these times when returning back to work or returning home after delivery, when challenges of milk supply and pumping and can affect breastfeeding continuation and success. To improve rates, the CDC and the CMS recommend expanding breastfeeding programs and reducing barriers to care. Lactation support is a cost-saving investment because a single lactation visit costs less than a 2-week supply of infant formula, making breastfeeding a significant, sustainable cost-saving measure. And breastfeeding support reduces reliance on expensive WIC formulas, which are subject to shortages, recalls, and can lead for families to resort to unsafe practices of alternatives. Lactation consultants work closely with families and medical providers to prevent feeding complications, support infant growth, and reduce preventable conditions to lead to fewer hospitalizations, provider visits, and ER visits. I respectfully urge the committee to maintain the current reimbursement rates and for lactation support to preserve the network adequacy and access for the Colorado families. Thank you for your time.
Thank you, Tara.
And that's all the public comments.
Members, what do you think?
This one, I also feel like the comment and the data really support sticking with where things are. I don't see anything that is a significant outlier, and similar to in the past, trying to stick to around 100% of state-based benchmark. I think Makes sense.
I generally agree. I wanted to confirm, just looking at some of the Q&A, that the April 1st, 2026 rate cut, which did impact some of these services, the data that we're looking at includes the impact of that cut, like it's not before.
The rates that we're looking at for this review, we utilize the April 1st, 2026 rates.
Okay.
Ling Ling?
Yes, that's true. The April 1st reduction applying to all code with appropriate Medicare rates. For some code, if they don't have a equivalent Medicare rates, and no impact.
Okay, makes sense. I'm comfortable with I think it would be consistent with how we've operated before of a Medicaid benchmark service to be around 100% of a benchmark, and these are above. And so I think leaving rates the same makes sense. Does anyone on the committee disagree or have a different perspective? All right. Then let's go with that. I will type that into the chat and let's keep going. Thank you, Megan. I appreciate it.
I know it's hard to moderate and type at the same time.
Thanks, Megan.
Thank you.
Yep. Appreciate you both. All right, prenatal plus. This is looking at a smaller end in terms of expenditures, 275,000. 448 members utilizing that, which is a decrease of over a third year over year, with just 5 providers, and also a decrease there, maybe by 1. Looking at overall the repricing, we'd be 82.5% of our benchmarks. There are 4 procedure code combinations with benchmark ratios. Other states are used as the benchmark here, and our range is 73 to 83. Prenatal care enhanced, with some variations here. I'm not sure of the variations, to be honest, but ranging again from 73 on the low end to 83 on the high end. Provider participation has been stable, about 100%. The panel size considers the number of members per site, and the members per site increased from 89 to 115, and then down to 89 again. Kim, I see your hand.
Thank you. I wanted to make one comment. We do have now 12 participating prenatal plus sites in Colorado, which is wonderfully exciting. And so this is a growing program. We just wanted to let you know of that slight adjustment. Thank you.
Drive time has about 97% within 30 minutes, and the PUPY has for expenditures slightly increased over the prior 2 fiscal years. Any public comments?
No public comment here.
Anything, members?
So I would say this, since we're comparing to other states, it sits a little bit lower than what we might consider for aiming closer to 100%, but it also is not like drastically low, given that most of these codes seem to be right around 80% of the benchmark. I think if we at our subsequent meeting will see a fiscal impact, I'd be curious to see what the fiscal impact of like increasing toward 100% would look like. but also could feel comfortable with saying that things stay the same, since it seems like there hasn't really been an impact in terms of participation in the program.
Specifically for that one code that I saw, was it 73%, not even in 80 to 100% range?
Yeah, there's the one, there it is. Thank you.
So what if we did this kind of two-path recommendation here? The ideal recommendation would be to bring it up to all codes up to 100% of the benchmark, because that's typically how we've talked about Medicaid benchmark services, which this is. And then the pragmatic recommendation would be to bring this one code H1005TH, 52 up to 80%. Are members comfortable with that recommendation?
The one in the chat from Megan.
That's the ideal, and then if I think she may be typing the pragmatic. Yes, yeah, exactly. Yes.
Thank you.
Are members comfortable with this?
I can support.
Yes.
Yes.
All right, great. Let's keep going.
Good work. Okay. NHVP analysis methodology. This is a recap. This includes 2 TCM codes and 8 physician codes that can be billed by RNs. This approach is unique to Colorado. Other states do not use these codes for NHVP. They consider whole packages for this. The 8 codes for physicians were reviewed under physician services, our 2025 review last year. But the 2 TCM codes were never been reviewed. So we proposed a solution here of a dual analysis. TCM rate only analysis would be easy to understand and implement using the TCM rates from other Colorado Medicaid programs as a benchmark, for example. And then an hourly package analysis. This could be more complicated, but gives us an idea of how the NHVP compares to other state Medicaid programs as a whole. It uses other state Medicaid NHVPs as a benchmark. Other states were selected here with the help of Invest in Kids and Changent. Uses the repriced amounts and the code level with time limits to estimate a, quote, Colorado repriced hourly rate, unquote. Note the fiscal 25 data were utilized for this analysis. We have several procedure codes here and a couple of different code types. The allowed hours were applied according to procedure code time limits and subject matter expert input, but the total Colorado repriced announced was divided by the allowed hours to determine the estimated repriced hourly rate, which gets us to $112 per hour. So Colorado TCM rates from other Medicaid programs were used as a benchmark on the TCM rate only analysis. Then you have those compared to TCM rates for child and for adults. And you get 64.9% for child and 61% for adults. Now on the hourly, we went against Alabama, Idaho, Maryland, etc. there, and 6 out of 7 there have hourly rates. And then Colorado would come up at 37% of the benchmark in this comparison. So there is a difference here. Now, Colorado estimated hourly rate was based on claims for all NHVP codes, the repriced amounts divided by the number of member hours per year. So to recap, we have it's not a lot of funds here, 188K, but serving 1,300 members, which is down 7%. 75 providers involved, but that's down 8%. Overall, taking all of this together, we would come out on the hourly at 36 or 37%. If we just did the TCM rate only, we'd look a little better at 61 to 65, say. There's your big outlier up in the upper right at just 40%. So for 25 anyway, the expenditures, NHVP tobacco, MSA funds were 23 million. Medicaid revenue from 2023 was 228,000. The utilization data from IIK showed the 3,700 families served, 37,000 visits. And then the estimated total cost per family served, combining those two sources, gets you to about $6,349 per family, or $633 per visit. And if we reprice that, we get the Colorado repriced amount at $188 and the estimated payment per hour of $112. So summarizing, the urban and rural panel sizes fluctuated, with rural panels increasing trend to a more rapid decrease in providers relative to that. And the penetration was just 27 of our 64 counties. Public comments?
Yes, we have 4 people signed up, starting with Melinda Davis.
Melinda, 2 minutes, please.
Hi, good morning. My name is Melinda Davis, and I'm a registered nurse with 26 years of experience in maternal child health field. For the past 15 years, I've had the privilege of serving families through home visiting. I'm representing Pueblo Community Health Center and the Nurse Family Partnership Program in Colorado. Before we get into the details of our recommendation, I wanted to remind the committee of the comprehensive nature of the Nurse Family Partnership Program that provides preventative-based care for first-time parents during pregnancy through the child's second birthday. With over 40 years of evidence, NFP has demonstrated measurable reductions in premature birth, low birth weight, child abuse and neglect, maternal depression, and emergency department utilization, while improving school readiness, maternal employment, and long-term family stability. Public health nurses deliver comprehensive, individualized care across the full continuum of maternal and child health, prenatal education and assessments, maternal health screenings and breastfeeding support, child development screenings, parenting education, safety planning, and coordination with medical providers and other community resources. Our request today for Mprrac is to formally recommend that HCPF adopt a comprehensive payment structure for NFP, structured as a per member per month rate of $880. A per member per month approach allows a more predictable budgeting so that agencies can estimate how many eligible families they'll serve and calculate the expected revenue accordingly. It also benefits the state by removing any incentive for programs to increase the visit frequency simply to generate more payments. Supporting this kind of equitable outcome-based payment for HCPF is already advancing through its alternative payment model. It is precisely the kind of preventative, long-term, relationship-based care that Medicaid should be sustaining, and Colorado has the opportunity today to make that possible. I'd like to thank you for our opportunity to speak today, and I hope that the committees consider this proposal.
Thanks, Melinda. Appreciate it.
Thank you. Next, we have Rosie Soto.
Welcome, Rosie.
Hi, thank
Go
you.
ahead.
Thank you. My name is Rosie Soto. I am a registered nurse, have worked in home visitation for almost 2 decades. I'm representing Denver Health and Nurse Family Partnership. I want to speak to the structural problem driving this request. There's currently no Medicaid billing pathway that adequately reimburses the direct nursing services that NFP provides. There's no code that captures the comprehensive nature of an NFP visit. Targeted case management was built for care coordination, connecting people to services. NFP nursing is something different. Registered nurses conducting clinical assessments, delivering evidence-based interventions, and producing measurable health outcomes directly. Prenatal health assessments, perinatal mood disorder screening, substance use evaluation, these are some of the clinical services that NFP does, and they're not referral activities. When they're billed under a case management code, the services are misclassified and significantly underpaid. A comprehensive per month rate per member solves this by building a payment model around what NFP actually is, a comprehensive nurse delivered home visiting service, not a fragmented set of billable pieces. Thank you.
Thanks, Rosie.
All right, next we have Allison Mosqueda.
Welcome, Allison. 2 minutes, please.
Hi, good morning. Thank you. My name is Allison Mosqueda, representing Invest in Kids with the Nurse Family Partnership Program. I want to begin by thanking Mprrac and HCPF staff for their continued engagement on this issue. As Rosie said, Nurse Family Partnership nurses are registered public health nurses, not care coordinators. They build trusted relationships with families over months and years through a continuity of care that improves maternal and child health outcomes. An ROI analysis provided to the department shows that for every dollar invested in Colorado NFP, we get a return of $7.90 in future savings for the highest risk families, with average cost savings exceeding $25,000 per enrolled family across all levels of government, savings that begin at birth. A Colorado Health Institute report commissioned by this department has already identified the need to move toward a comprehensive payment structure for NFP. States such as Alabama have implemented this model with success. What Colorado NFP agencies need is the same stable, predictable funding through a prospective per member per month rate of $880, aligned with the work of the RAISE and HCPF's maternity alternative payment model. Our ask is clear: a formal recommendation from Mprrac for the department to move toward adopting this comprehensive per member per month payment structure. Investing in a proper reimbursement structure now is the fiscally responsible choice. The alternative is paying a much higher price later when families will lack the preventative support that keeps small issues from becoming costly crises. We understand this will require a deliberate process of analysis, review, and engagement with providers and partners to assess the feasibility and design. Our organizations are prepared to support every step of that process. Thank you.
Thanks, Allison.
Thank you. And lastly, we have Matthew Richardson.
Welcome, Matthew.
Thank you. Yes, my name is Matthew Richardson, and I'm with Changeant, the national office that supports nurse family partnership programs across the country. And I want to offer the committee some context from what we've seen elsewhere. In states that have established a comprehensive Medicaid reimbursement rate per family per month, such as Alabama, as you've heard, programs have stabilized and grown in ways that fragmented billing structures simply can't support. A per family per month rate that reflects the actual cost of services is beneficial to programs serving families because it provides a predictable Medicaid funding stream around which the organization can build a budget with less guesswork. The same arrangement is beneficial to states because it removes any incentive for a provider to drive up the number of visits that may occur to maximize reimbursement. As we have supported similar Medicaid exploration conversations in other parts of the country, states that acted early protected their programs through funding transitions. States that waited saw harder recoveries and in some places permanent loss of capacity in the communities that needed it most. Nurse Family Partnership has 45 years of evidence behind it, but evidence alone doesn't keep a program running. Sustainable financing does. A comprehensive per family per month payment is the most effective lever available to keep NFP viable statewide, including in rural and frontier communities where this nurse may be the only consistent clinical presence that a family has. We have examples like Alabama and elsewhere nationally that can be built upon. We're ready to work together with the department and invest in kids to support Colorado to move towards a comprehensive per month payment structure. We strongly urge this committee to move forward with that recommendation. Colorado has the opportunity to ensure the sustainability of NFP, and we're ready to support that work. Thank you.
Thank you.
All right. Yes, thank you, everybody. So that's the last public comment.
Members, questions, comments, recommendations?
Thank you, everyone, for the public comments. It's helpful. So just to clarify for the HICPUF team, this kind of per member per month rate, that could be a policy recommendation that we make, but the Mprrac recommendation is more around the percent of benchmark like it is with every other service. I'll take a nod as a yes. Okay, great. Okay. Members, any suggestions here on what to recommend?
I think this one is really tough because I agree that there really is more of a structural issue here, and I am curious about the data that was presented, because transitional care management codes are typically used for patients that are discharged from the hospital and within the first couple weeks, and we're talking about effectively two patients if you have a mom baby pair, but it is also over an extended period of time, which is maybe a little bit more analogous to chronic care management services, as was alluded to. So I'm just curious to what degree the populations that we were looked at, those kids and the adults that were used, how similar is that to this population that we're talking about, which would largely be healthy mom babies, say as compared to complex discharged patients, but they're also two individuals and it's a much longer period of time.
Kim?
Yes, so Megan, we'll probably want to circle back to your question. I might see if Lisa has a good answer for that one. I was going to mention or respond to Ian. He was asking about the benchmark, the comprehensive hourly analysis that could be looked at also in a per member per month way if we're assuming members average around two visits, per month, to 1 hour visits, if that is helpful for the benchmark question that you had, Ian. But Megan, I might direct your question to Lisa Mprrac, our policy person.
Yes. Hi, Kim. Hi, Megan. Thank you, Kim. I am Lisa Mprrac. I am a maternal child health manager here at the department. And Megan, I don't know if you could rephrase your question around, I wasn't quite following what you were asking about in terms of the mom and the infant. If you could rephrase it.
I'm just trying to conceptualize between these two different benchmark methodologies, like which one I would feel most comfortable with. So to understand the TCM benchmarking, it looked like you had taken kind of typical rates for adult populations and for pediatric populations, and then try to compare that. But my understanding of those transitional care codes is that it is post-hospital follow-up within 7 to 14 days, unless the ongoing sort of care, right, which would be more chronic care management. So I'm just trying to get straight in my head how those codes kind of relate to this service.
Okay. And then I agree with everything Megan said, and to also just broaden it out a little bit more of which of these two methodologies do you all think is the better methodology? Because they have fairly different numbers associated with them, and yeah, which one is better and why?
Sure. Let me speak to the TCM. And the TCM codes in this instance actually stands for targeted case management. So it's not transitional care, it's a targeted case management that we will provide the dyad, the mom and the infant, over the course of 2 years. And the challenge with that code, as I think you heard from the testimony, is that it doesn't really capture the full scope of work that is provided throughout those 2 years, the services. It's only capturing the TCM. And Kimberly might be able to speak more to it, but you're right in the challenges that we had looking for benchmarks on how we're using that code versus how other states are using that code. It was kudos to Kimberly. She really did an outstanding job, I think, finding what she could in order to actually build a benchmark. Great. In terms of which do we recommend, I think it's hard to say I want this one and not that one, but I can say that the hourly rate or the per member per month rate, either one, does do a much better job of capturing and reimbursing the services that are actually provided through this program, as opposed to just the limited TCM code. And I open it up. I think my colleague Annette is on the phone. I don't know if she would like to add anything. She oversees this program from HCPUF's side, or Kimberly, if I misrepresented anything in the analysis.
No, you are correct. The benchmarking for this service was very challenging because a lot of states that provide the similar services, they provide this through a package rate where all the services are together. Our nurses in Colorado bill either these TCM codes or some of these codes that overlap with physician services, which is completely different from what other states do. And so that's why the packaged analysis kind of gives you a wider view of how we compare with other Medicaid programs currently.
Okay, thank you. So my thought here would be to do like an ideal and a pragmatic. It sounds like uh, the hourly package appears to be a better way to think about it. And so an ideal is a Medicaid benchmark service. So an ideal of 100% of the benchmark and a pragmatic of 80% of the benchmark at the high versus low end of the range. And then a policy recommendation for HCPUF to review and consider adapting the PMPM model that the stakeholders recommended.
I can have both of those prepared for you in August.
Any feedback from the committee on that recommendation?
No, I agree. Like, I think that would be really helpful to see at both ends, and that, yeah, really the policy recommendation hopefully is what will ultimately be able to move forward in the future.
Yeah, I would agree with Megan on that. I'd like to see how it kind of looks when we see it next month.
It would be in August, to clarify.
All right, I'm typing it into the chat.
I think this responds as well. There was a chat from JJ Gorsuch about this, that this is a forum where we can make those policy recommendations. There's no guarantee those work, but this is a way to affect that and explore those.
All right. Any other comments here from the committee? If not, I think we can keep moving. Are we at lunch right now?
Yeah, we're traditionally we've stopped about 11:30, but we do have abortion, which is still part of maternity services. My thought would be maybe we look at that and then take the break because it just functionally might feel a little more natural.
Yep, sounds good.
Okay, moving in. Total expenditures here, just 23,000. We suppressed the count due to PHI. We have 122% increase in members, just 11 active providers, and that's an increase of 57%. And the rate benchmark comparison here is 132. We usually take about 20 minutes on the lunch break. Yeah. Oh, thanks, Michelle. Look at you.
I got here just in time for the lunch break.
Rate comparison analysis summary here. A lot of detail. Just need a little more font size. Thanks. We have 9 procedure combinations. 4 of those have utilization, 5 do not. We have used other states as the benchmark source here, and the range is 71 to 158, so fairly broad. All utilization is blinded to protect PHI, and we don't have an outlier chart here. But you can see the benchmark ratios range. On the low, 1 is below 80% there, number 7. All access to care metrics are excluded at this point, but provider participation range from 10 to 17%. Prior budget request to add modifier 22 to code 59841 was not approved. There was a significant rate increase in July of 2024, 2 years ago, from 200 to 1,000 and 260 to 1,600. The benchmark rate over 100 compared to benchmark states, again, 122 and 134 for 59841. And comparing states, none use modifiers to differentiate procedural complexity. Any public comments?
Yes, we have one from Jack Peter.
Welcome, Jack. 2 minutes, please.
Great. Hi, members. Thanks so much for having me. We continue to push for the creation of modifiers here to accurately reimburse for certain abortion care. These codes vary enormously in complexity. Some of this care takes 10 minutes. Some of it takes several days. We've provided lots of documentation and evidence to this group before, so I won't belabor that point, but direction and support from Mprrac is essential for department staff to be able to move this forward. We've been working with the department on this for a few years, but they need your blessing to be able to move forward on this. So please consider the use of modifiers for these services. I know other states aren't using them. The majority of states in the United States have banned access to abortion care. Comparisons to other states are not accurate when it comes to abortion care in particular. And there are states that have a variety of other billing mechanisms that I know this group can't consider because they're not on the published fee schedule, but they exist. There are additional supplemental payments that the states are giving to providers of more complex later care. So there are precedents for these. We've shared that information. I know it's a little bit different. That's how abortion care is going to be. It's always just going to be a little bit different. There is not a good precedent for those services. Thanks very much.
Thank you, Jack.
Thank you. No more public comments.
Members?
Any feedback here from the committee?
Just a question with respect to those modifiers. I guess what options do we have in terms of making that sort of policy recommendation? Because my understanding was, obviously, we don't create modifiers, and we talked about the recommendation of like going to the CPT committee to sort of work on creating different tiering for abortion services at the origin of those codes. But I'm curious, like, what other avenues are you referring to for states that would sort of provide those options?
Certainly. Thanks for that question. I think based on our conversation with the department, we don't need to create new modifiers. We have existing modifiers that can be used for these purposes. I think the thing that feels the best operationally for the department seems like it is very much based on gestational modifiers rather than complexity. Complexity can be difficult to prove. I think there's going to be a lot of back and forth between the department and providers, potentially, potential clawbacks. But when you do it based on gestation, there's kind of pretty clear delineations there. My colleague Kate Hayes is on the call as well, and she's kind of a national expert in this space, and she might be able to provide some additional detail on how those modifiers can be used.
Yeah, I think we understood your position previously. If there are different avenues that you had suggested to pursue in order to change the rates and try to establish a new national benchmark in order to allow Medicaid to follow in the footsteps, not create new sort of policy. What we're asking here simply is to ensure that there are payment differentiations when we get into later gestational age abortion care. Because as Jack and I have spoken previously in this space, this is one of the very rare procedures that exists in the world that has a wide differentiation within the same code. And that is what we're trying to fundamentally correct here. And your point is fair. This would be one of the first states to do it, but that's how Medicaid works. Is one Medicaid creates the policy and other Medicaids can use that as example because of the good research that's been done and provided to this team as well as to the department over multiple years about the range of complexity that is occurring within that second trimester. We're not asking you to create new policy about implementing modifiers. I completely understood your position last time we all met. But what we are asking here is to consider that there do need to be payment differentiations. Our suggestion was to do it through the modifier system because that's how claims get paid within Colorado Medicaid. It reflects a modifier and a CPT code and a diagnosis code configuration that then spits out the appropriate reimbursement. So we were working within the existing billing structures that occur and extending those a little bit. So that's what we're asking you to do. I did love your suggestion of like, go to the national bodies and plead your case there. And that is on my list to do, absolutely. And this is the mechanism in front of Mprrac right now to demonstrate support to the department, which then we are looking forward to working along with our colleagues in this space to really hammer out what the ranges look like.
And what are the modifiers that exist today? Can you just say a little bit more around what they are?
Yeah, so there is one right now, the modifier 22 that was referred to on the previous slide. It is eligible to be appended to any gestational age of 18 weeks or greater for gestational age. It does tend to, modifier 22 exists in the world apart from abortion coding. And it is a payment altering modifier and it tends to either double the rate or do 1.5 times the rate. And so that's why we were suggesting it as applicable to here and ensuring that it is a payment altering modifier. And then I suggested various other modifiers. Ian, I can resend the document that we had suggested before that gave you this sort of gestational age bands, the recommendation for the modifier and the recommendation for the rate based on our internal Planned Parenthood costs. So that should be actually entered into record. I'm sure that the team has it. Michelle, I think you've got a copy of it when I sent it a couple of months ago. But I don't have the other ones just offhand. Those were ones that I had extended, but modifier 22 is absolutely in practice in the medical community to identify more complicated care. And with specific reference to abortion, it is generally allowable within 18 plus gestational age.
Okay, thank you. And I see it here in our folder, so it's ringing a bell now. Thank you.
I mean, I certainly support making that recommendation again to like consider using that modifier. I think the easiest thing is to use things that actually exist. And then beyond that, I think it's just making the suggestion that, the department work with specialty societies and involved folks to come up with a system that that might work. But otherwise, I think for where the codes are set currently, those seem like they're within a reasonable range. I think there was just one that was on that grid that fell below our like 80%. But I overall feel comfortable with where the code set is sitting right now.
Members?
Jack, were you going to say something?
Yeah, thanks, folks. I'm used to testifying in legislative committees, and so usually it's only responding to a direct question. I think process-wise, my understanding from HICPUF is that they need the support of Mprrac to be able to engage in the conversation with us about having a possible payment differentiating modifier. We're not asking you to come up with those rates now. I don't know what that would look like, but in order, like our next step that HICPUF needs is permission from you all to engage with us on figuring out the process that might be best. There are other avenues, right? We could run a bill through the state legislature. HICPUF has asked us to do it this way. And so we want to be good partners with you all and with the department. Again, this is like a multi-year conversation. We can use the sledgehammer of legislation. We've done things like that before, but my understanding is sort of the best next process here is to empower Medicaid staff to apply a payment modifying modifier here. Figuring out what those are, that's a separate conversation, right? That will come back to you all for rate setting. But the next step around, is this something that can have additional bands? That is the question that HICPUF needs answered. Thank you.
Thanks, Jack.
Okay, so I think to synthesize it, I think the base rates do seem generally sustainable here. So a recommendation could be to bring this one outlier code that's below 80% up to 80%, 59852, and then a policy recommendation to have HICPUF evaluate the use of modifier 22 or other modifiers that adapt or that take into account the varying complexity within the code. Or how would members feel about that?
I agree.
I also agree.
All right. Any dissenting opinions? All right. I will type this into the chat right now and let's keep going.
Yeah, I think we're ready for a break, everybody. I suggest 20 minutes, if that's all right. We could reconvene at 12:10 and pick up with PBT. How are we doing, everybody? Good lunch?
Good little break.
Yep.
Got another coffee, so I'm good to go now.
Let's keep going.
I had a grilled cheese.
Oh, delicious.
All right. Do we have our members here? Everybody back?
I think so.
Okay, good. Let's dive in. Excuse me. Pediatric behavioral therapy. All right. Here we're looking at about 276 million in total expenditures for 7,000 members. That's an increase of 12% year over year, with 1,100 plus providers, and that's an increase of 20% year over year. When we benchmark these out, we have other states' commercial rates and TRICARE rates, and we are either 92% against other states, 118% of commercial, or 92.6 of TRICARE. We have 6 total procedure code combinations. One was excluded. As we mentioned, other states, the benchmark range is 82 to 101. Commercials vary a little more broadly from 54 to 123. And the TRICARE range from 76 to 120. I saw a question about the dates. We had those dates were 2+ years ago. As far as the individual codes and utilization, we look at these as a percent of utilization, adaptive behavior, number one here is by far the largest, 86%. Row two basically rounds out 99% of the category. And both those are over 90% on the benchmark for TRICARE, over 117% for commercial, and 86 to 93 for other states. SERIF data, in this case, the department had met with SERIF to review the data, suggested filtering, for example, NPI taxonomies, and the department applied this change to the commercial benchmark. For the CIVHC data, we have a payment provider tool for the 25th, 50th, 60th, and 75th percentiles. Due to a back-end issue with visualization, some data was not properly displayed when filtering selections were applied, and this issue was not related to data quality and resolved in January. So for PBT, all payer expenditures, this would be new analysis since our last meeting. Expenditures per utilizer per year go from 22, 23 through 24 and then 25. And you can see that increase there across commercial and Medicaid in the top part of the chart. And the average expenditure per year, again in blue, commercial moving from say 449 up to 609 in the last full year of data. And similarly on Medicaid, moving from 569 to 837 over that same period. Overall percent in change in rates from July 23 to October 25. For 97151, we saw a 162% increase over that period. Smaller increase for the TJ multiplier or extra code there, modifier. Then 20%, 22, and 15% increases for three more codes there. And then a decrease in 97158. That's the pink chart on the right. And you can see that decrease there just in last October. Bubble chart, we have the one outlier here, 97158. At 55% or so of the benchmark. And then 97156 and 157, we break these down. Estimated rate based on 100% of the benchmark state rate. That would be $24 and $10 respectively. And then multiplying those out, you can get to a fiscal impact. And then the GF total of 11 million on the right side.
Brian, can you go back a slide? Just quick question on how are we calculating the fiscal impact here? Because 97156 isn't covered, and so how are we estimating the fiscal impact if it's not covered today?
I think we'd asked because people wanted it added, or we heard from stakeholders that there would be value that we wanted.
No. That's not my. I agree. I think it's a good question. It's more like a math question. Like how do you estimate the impact of something that it doesn't happen right now?
I'm gonna need help.
Kim, please chime in because Kim did the analysis. We collaborated with the internal policy coworker. Okay, use other code as the proxy.
So let me grab We used the other codes as proxy data. Let me grab the steps that I used. We So we used data from 97157, 97155. We did our 497157. We used 97155. We looked at the current utilization of that code and looked at how many distinct utilizers there were utilizing this code. And we assumed or made the assumption that for every utilizer that utilizes 97155, they would utilize around an hour per week, but not for a full year because of this is 97157 is a group code. And so we assumed that that would be a 4-month type code. And that 4 months was determined using the other group code, utilization 97154. For 97156, we used right at 35% of the utilization for 97155 because of certain similarities, but because of the type of code, we are assuming it wouldn't have the full utilization that 97155 has.
Okay, thank you. So you're basically using some high-level assumptions of what utilization would look like, applying that against a potential 100% of benchmark, and that's the column.
Yes,
Okay.
yes. And the benchmark was taken from the same states that we used for all the other benchmarking and those specific codes for the states that do cover them.
Okay, great. Thank you.
Thanks, Kim. So provider participation was at 85% in 22, 84% through 23 and 24, and increased to 90 in 25 or through 25. Stability rate, the provider continuity was about 54%, with an entry rate of 30 and an exit rate of about 24. The drive time map shows 90% of members live within 30 minutes of their provider or a provider. And the Medicaid PUPY expenditure shows they're higher than commercial expenditures and an increasing trend over the last 3 years. And the Medicaid PUPY metric shows Colorado utilization is similar to that of commercial. Public comments.
Yes, starting with JJ Tomash.
JJ, welcome.
Hello, thank you.
2 minutes.
Here we are again. Thank you guys for your time. PBT serves children with autism, which is probably about the best investment in the future I can think of. And we are an industry that's been in crisis. A few years ago, you guys met and recommended a rate increase for us, which had a huge impact. And we're in crisis again. We've gotten disproportionate cuts this year compared to other services. As far as I know, I think we got the biggest cuts of all of the services. And the benchmark states make sense. These commercial comparisons don't make any sense to me. There's simply no way that the rates pay that much lower than Medicaid, and I'm sure other providers here would agree. There's something going on with those numbers that doesn't make sense on the face of it. So I just ask that we look into that and that we lean more on the benchmark states, which is why we chose them. And that's all I have. Thank you, guys.
Thank you, JJ.
Okay, next we have Amanda Malott, but I know she's not here at the moment, so Will Martin will be speaking on her behalf.
Hi, everyone.
Will?
Thanks for the
Go ahead.
time. I'm going to read a statement here from Amanda. So, good afternoon. My name is Amanda Malott, representing Action Behavior Centers, and I'm here to raise concerns about the validity of the commercial price transparency data being used to justify rate reductions for children with autism. First, the data source is compromised. Beacon Health Options, a key contributor, no longer exists as a recognized entity. It's been absorbed into CareLeon, transitioning from a nonprofit to for-profit model under Elevance Health. This organizational transformation fundamentally skews the data set, and only Anthem/Elevance data should be used and considered for that submission. Second, over 20% of the Colorado market is missing. This analysis completely excludes Kaiser Foundation Health Plan and Centene Corporation, which together represent more than 20% of covered lives in Colorado. Kaiser alone holds a 12.58% share, and Centene holds an 8.24% share, both larger than Aetna, which was included. A data set missing 1/5 of the market cannot serve as a valid benchmark. Third, there was no cost of living adjustment applied. HCPF applied a cost of living adjustment to the Medicaid rate analysis at the request of the Mprrac ABA work group, yet failed to apply the same normalization to commercial rates. This inconsistency ignores wage inflation, workforce cost pressures, and the actual provider cost of operating in Colorado. Fourth, surrounding states were excluded. The Medicaid analysis uses surrounding states as comparison data, yet the commercial analysis was limited strictly to Colorado. So in summary, the data set's incomplete, inconsistent, and economically unsound, and I urge HCPF and Mprrac to conduct a methodologically rigorous analysis before making any rate determinations. Thank you.
Thanks, Will.
Okay, and Will, you had also signed up to speak, and you're next on the list if you'd like to go ahead.
Yeah, thank you. So my name is Will Martin. I'm here representing the Colorado Association for Behavior Analysis as the chair of the Public Policy Committee. I also want to echo what JJ and Amanda shared. I have a lot of reservations about the commercial data set being used here. I tuned into the NEMT conversation, and I heard a lot of context and reservation about the commercial data set that was selected there. I didn't quite see the same caution applied to the PBT commercial data set, and I think that that's missing and a bit troubling. So, we have engaged in hours and hours and hours of effort with this group and with HCPF to establish the Medicaid benchmark states. I don't want to introduce a new data set just because the conclusions might be inconvenient in the current budget environment. And so I think you can find a data set that provides the answer you're looking for in any situation. And I would encourage the department and the Mprrac committee to really stay true to the methodology that we've agreed to, which is using Medicaid benchmark states. Thank you.
Thank you so much. And next we have JJ Gorsuch.
Welcome, JJ. You there? You're on mute.
I'm not sure I see him on the list.
He's here. He's just on mute.
Oh. I see a JJ Tomash, but he already went. This is JJ Gorsuch.
Oh, Gorsuch, yeah. Going once, twice. Okay.
All right, next we have David Hatfield.
David?
Hi, guys. Good to see you again. I actually
2 minutes, please.
Yes, I know. I did submit some written because this is more methodological and there are multiple questions and errors. I just asked you to take a look at it because, especially with regard to the commercial, there is also a selectivity issue with primary versus secondary in our population group. Needs-based models. If you look, I'll just leave it at that. Please take a look at this, and I know the providers within the panel are going to understand quite a bit of the methodological challenges that I'm relating in there. Thank you very much.
Thank you.
Thank you. And we have Joshua Pritchard.
Joshua?
Yes, can you hear me?
Yep, go ahead.
All right, thanks. I was on the last call that you had the folks that had the commercial data that was being shared. And I met with them after, and I was able to look through, and it appears that the numbers at least shared there were sort of a simple average of per provider. And I wanted to kind of echo what everybody has said, that it's concerning that commercial rate calculation. It's really important that it's done either utilizing claim volume or looking at where the market actually pays versus just contracted. There are a large number of small providers that have sub-market rates. And if we simply average by provider instead of who's actually serving, we're going to get a sub-market average, and they're not people actually getting services and don't represent a viable option. So wanted to reiterate, I think the commercial is concerning. Not sure why we're using commercial as a comparison anywho, but wanted to point that out. And there, I think, are plenty of folks willing to spend a lot of time volunteering to help with that and make cases of how to best model that represents a fiscally responsible option. Thank you.
Thanks, Josh.
All right, thank you. That looks like the end of public comments. I know Kevin Martin wanted to chime in regarding something. Oh, actually, we do have one more. She just submitted it. Abigail Koenig.
There we go.
Yes, hi. I
2
apologize.
minutes.
I was just filling that form out. Thank you for letting me do a last minute submission. My name is Abby Koenig. I'm the founder and executive director of Colorado Autism Consultants, an organization devoted to bringing access to care to our most under-resourced and underserved populations of our state. Recent Mprrac benchmark data showed a striking paradox that Colorado Medicaid spends more per person on ABA services than commercial insurance. While I also have concerns about the data sources of that, I also can see a specific variable that I don't think we've really spoken as much about it as should be considered, which is the exclusion of the nationally recognized CPT codes of 97156 and 97157, the two codes in our code set directly focused on parent training and transitioning interventions to natural environment supports. While commercial payers in other benchmark states reimburse these codes, Colorado bundles them, not reimbursing for this individual service. While Colorado does mandate that parent training occur, the compensation for this labor is not allowed. It skews our benchmark data, and it forces providers to directly absorb these costs and or select models that rely more heavily on direct service rather than selecting models that may be more efficient and effective even for some clients from a clinical standpoint, but which Colorado Medicaid providers cannot provide. As a BCBA, we're bound to deliver evidence-based care. Multiple models are available, but the current framework makes some of our most efficient models not allowable. By activating 97156 and 97157 to match national standards and reimbursing these services fairly in line with other states and commercial payers, you would allow Colorado providers for the first time to be on a level playing field, and would allow us for the first time to consider the full scope of clinically appropriate treatments for our clients.
We're at 2 minutes, Abby.
And I think that summarizes it. Thank you.
Thank you.
Thank you. And that was the last public comment. And Kevin Martin, if you wanted to chime in.
Yeah, I just wanted to respond to, I guess, the concern about it not cautioning enough about the using the commercial data in the PVD space versus NEMT. And I guess I'll just correct that now. First off, I'm sorry that we did not express that more clearly, but I want to just say we don't usually use commercial data. We only use that at the express request of providers. And even when we do use that, I want to just say that there should be extreme caution in using any kind of commercial analysis to make decisions. It is inherently flawed because the commercial data commercial sector has incentive to obscure data to us or to just not share it in general. So there is I don't want to say it's impossible, but we have not found any way to actually do a good, robust analysis against commercial data. So I know we've mentioned that many times in the past. We've gotten a little bit lax on that. So I'm trying to correct that now, that please take any commercial analysis that we are doing with a grain of salt, because it will always have big holes in it.
I think
Thanks, Kevin.
Kevin and Brian, that would be a good discussion for our November meeting of just when do we say yes to commercial data or not? Because it seems like 1 or 2 times a year we do it, every other time we don't. And it seems very kind of willy-nilly when we do or don't. And just having like a Mprrac standard on when we do versus don't, I think would just help everyone.
Thanks, Ian.
That sounds great. I would love to have a standard. I know we've just sort of been doing it ad hoc up until now. And, we're, again, just trying to help everyone here. Yeah. And so I think there's inherently an assumption by one person's experience that, that if we look at it more holistically, it's going to reflect their experience, but that's not always the case. And then it's further obscured by the inherent flaws in the data that is available to us. So, I guess just overall, I really, really hesitate to use the commercial data at all. However, it is actually in the law that we use it when available. It's just not really available robustly ever. So.
Thanks, Kevin. Members, other comments or questions, recommendations?
Yeah, I'm going to disclose I'm a owner of an ABA practice, so that is my conflict of interest. And Kevin, when you were just saying that, I pulled up one of my provider contracts and I'm like, how does this compare to what I get? So it's really interesting. Yeah.
Yeah, and that's, I guess, a great example of just the difficulty with commercial data is like, not only are there a lot of different commercial companies, like payers, but then they have individual contracts with every provider. So you have like the number of payers times the number of providers, different rates to take into account. Right. And we'd be lucky to get half of those. But like that would be incredibly optimistic.
Well, and it's
more
very
realistic is that we're going to see like 5-10% of that.
Yeah, and it's very clear, like you're not supposed to share this information. The only people who know about it are supposed to be. So I'm like, how did you source this, or how does it get sourced? And then it also changes because there are accrediting bodies that get paid and reimbursed at higher rates because they've exemplified higher standards of care. So there's that incentive when you're accredited to you get, yeah. So I think it's interesting. I do wonder though, and I echo some of the sentiments on why fundamental tenets of ABA therapy are to generalize behavioral change into other naturalistic and appropriate environments. And so I do and have often wondered why 97156 is not a covered code. And I would say that in order to bring down, because these numbers are staggering that the state pays for these services. And so we have to be, I think we have to be like very clear that this is a very expensive part of the budget. But being able to generalize those services and teach parents how to do this outside of clinic and direct care settings is paramount to bringing those numbers down long term. So if you can't work with parents to do that in an effective way, then how are we supposed to, sort of curtail some of these budget issues that we see? I think that would be my biggest kind of overall concern.
Is there a reason that 97156 hasn't been covered? Does anyone from the department understand or know the history or rationale?
Hey, Gina, are you on the phone? Could you please chime in?
I am here, Ling Ling.
Thank you. Thank you.
Yeah, that was a decision made by our rates group a ways back, and it's something that we have been looking at each year to add. So the original decision was made by rates.
Questions?
I'm sorry, Gina. I think we'll have to take that offline.
Okay.
I disagree, and I'm sorry that we are bringing this up in a public forum.
Sounds good. I think, like Nicole, we also provide ABA therapy. I think like the arc of this service, I'll start with, and then my thinking on a recommendation. I'd love to hear others. I think a few years ago in 2023, the community was in a really dire spot, meaning clinics were closing left and right. I think 10 to 15 providers left the state, and it was a really challenging time. There was a bump, that's the bump that's in these slides, and that really made a difference in 2024 and 2025. I think that helped stabilize the field. And then going forward, I think there's been more challenges recently, meaning there was this large targeted cut that came last year, and then there's several new licensing standards that are coming into place, which are good. We think they'll support access and to quality care, but are more expensive. And so you've kind of gone through this arc of like way too low, a correction up, and then a correction down, with more expenses coming in the future. And so I think it's in a more challenging spot than it used to be, though not as dire as it was back in the challenging years of post-COVID. So I think we should use the kind of ideal versus pragmatic here to our benefit. And I think like I would say like an ideal of 100% of the Medicaid benchmark and a pragmatic of like leave rates where they are. And I'm curious what the committee thinks of something like that.
Kind of a pile of questions before I feel like I can weigh in on that. If I may, it was helpful to have some of that historical context, as one of my questions was the sort of relative rate increase for the 97151 was much higher than others. And so I'm curious like why that was, and was that something that felt like it was stabilizing? And then the other, just to verify that the benchmarks that we're looking at are based on the most recent rate decrease that happened. So
You start with the last question, and then I can add in on 97151. And Nicole, you should add in as well. But on the second question, Ling Ling or others, can you chime in?
Megan, could you please clarify your second question?
So when we're looking at the table of benchmarks, those are the present date rates after this most recent rate decrease that
yes
reference.
Yes.
So
yeah.
We're sitting in this 80 something to 100 something percent
yes.
of our state's benchmark based on that recent decrease.
Yes. Yeah, it's the most recent. Because on July 1st, the PPT rates exempt from the 2% over the cross-border reduction. So the data now we see it's the most current rate, even after July 1st.
And was some of that rate decrease, or the feeling that there was a need for a rate decrease, driven by this concern about the difference in spend between Medicaid and commercial on these services, or what sort of was underlying that?
The reduction is back to last October, the October 1st. It's based on the governor's executive order because the state had a budget that has crisis. And they made a decision, especially the PPT received a more than 20% of targeted increase effective on July 24, based on the 2023 review. So they think the PPT get a huge increase. Then they want to pull back some saving for that, 5% reduction.
Okay.
Yeah.
I mean, do we think that there's
And then
something
on the
significantly
commercial
different?
versus Medicaid, Megan, just to bring it to life for
Yeah.
you, there's a Medicaid buy-in program for children with autism. So you can buy into Medicaid at higher income levels. And so the dynamic for commercial families is that the kids with higher severity who get higher services have the highest copays and deductibles and spend the most out of pocket, so that they then apply to the Medicaid program and then they're covered by Medicaid. And so there's this like built-in incentive that drives what you're seeing there that's independent of the like actual utilization patterns. It's families trying to get coverage for very large copays.
Yeah, I think that was my next question, was just to understand, like, is there something significantly different between the commercial population and the Medicaid population? So it sounds like we think more complicated patients are going to end up applying to Medicaid, and so they may be somewhat different groups. All right, and then I'll let you answer my question about the impact of the more significant increase on the 97151.
So go ahead.
No,
I think it's a very important code. It's a treatment planning code, but it's a small code. Like if you look on slide 73, it's less than 1%. So it's a small code. The other thing I would say is the way that Medicaid administers 97151 is different. So it's not, I don't think it's a good apples to apples comparison for reassessments. It's capped at an hour, which is very inconsistent with how other state plans or commercial plans are run, and so it's distorting the analysis because the truth is teammates do treatment planning anyways, they just don't get paid for it, and so it kind of distorts the benchmark artificially.
No, it's an evaluation code, and most payer sources, they bill it out per 15-minute increment. And so you do your evaluation and then determination for the type of services, the amount of services that are needed, and then write your intensive treatment plan. And so Colorado bundles all of that into just one flat fee, whereas other payer sources do this in 15-minute increments. Or hour increments, or so it's analyzed differently. So that's what, but I think it was not being utilized correctly before. This gets us closer to what it should be. Yeah.
Thanks for
Kim?
that. I'll let Kim answer, then I have one more question if you'll entertain me.
What Nicole was saying is correct. So in Colorado, the 97151 that you see here, that's for all the initial assessments. It's not for the reassessments. You can bill it once per year. It's an 8-hour flat assumption, just assuming that one thing takes 8 hours. The benchmark states all do 15-minute increments for this. So we adjust the 15-minute increment to the 8-hour assumption that Colorado has, and that's how we make these two comparable. But there is a difference with 97151 in Colorado versus the benchmark states. And that's how we adjust this 97151 with the modifier TJ. That is the one exclusion in this set of codes, because other states similarly do things differently, and we couldn't come up with a good way to benchmark that specific reassessment code, if that helps answer your question.
It does.
There.
Thank you. So my last question is just with respect to the 97156 and 97157. I am curious, I think I heard somebody mention that if those codes were used more often, that there might be a means of like shifting other services or not needing to rely on individual services. So I'm curious if there is a sense that there would be an appreciable decrease in some other code or codes on this list, and is that considered in this fiscal impact, or is that feasible?
Oh, Megan, I think this is a good assumption, but we don't have the data for fiscal impact. We only can based on historical data. We can use fabricate, just like we supposed to be this. We cannot do that way, sorry.
But just to bring it to life conceptually, I agree with Ling Ling. It's an impossible thing to model, but 97156 is a caregiver training code. So a child comes to services and you're trying to train the mom, dad, or caregiver on the treatment plan so that they can implement it on their own in the home setting. And so you get a positive benefit on outcomes, which should reduce the direct service utilization. The 97153 code, which is the code that has the greatest utilization here. So I think there is a conceptual underlying, but yeah, it's hard to model.
And since it hasn't, we haven't been able to use it, I think that we would kind of be trailblazing there to see. I don't know if there are any other states that have not had this code and then implement the code, and then if there's any data we can extrapolate from that, but we wouldn't be able to know.
Yeah, thanks for that. Thanks for.
But I also think it begs the question, like if in pediatric services, and especially we have codes in other, behavioral and mental health services for parent caregiver training, or consultation with parents without client present, with client present. And so if we're affording that to, just as a matter of equity, and especially because we're talking about potentially in some cases some more intense and really like complex interventions, why would we not apply that here as well?
Okay. Any potential recommendations from members in light of all of this?
I guess my question is, we've kind of talked about with the abortion discussion, we talked about the modifiers and making suggestions for the 22 modifier for the abortion codes. Are we able to make suggestions for the implementation and use of the 97156 and 97157 codes through this committee?
Yeah, you can make, I think
it's a policy recommendation similar to how it's something we can advise, and the department can choose to do what they want with it.
Yeah. There's really no limitations on the recommendations that you guys make. In general, we tend to focus on just altering the existing rates because that is something that we can model out and put into the sort of standard process. It's much more likely to actually get action. The more I'm gonna say esoteric, but it's really not that like far out of the norm. But the more policy driven or other suggestions to like add codes or change payment methodologies, etc., those are absolutely within the purview. It's just they tend to not be as actionable, especially in the short term. So it usually ends up leading into longer term projects that take years.
I would say then the 97157 code would be the one I would not recommend. If we were to try and tier it out, it would be 97156. And that's the one that's most likely to be utilized by providers, since we do most of our work in individual models rather than group models. And I think the utilization for the group code shows that that's the case as well. So that might not be, I think, effectively the one that gets the most impact for long-term decrease of utilization for the more expensive and ongoing therapies. And so I would say if I were to prioritize in terms of an ideal sort of policy suggestion, it would be to implement the utilization of the 97156 code, knowing that we're going to have a fiscal impact and that we're in a budget year where that might not be awesome. um, we might even, I mean, I would even consider saying we don't even have to go to 100% of benchmark. I think just having the open code would be great to start out. And we can potentially even say like 80% of benchmark, or I mean, ideally 100%, but something in there that gets us the code enacted.
Yeah, I think I would love to see what the fiscal impact for those codes is at 80%. It feels hard to make a recommendation without like really knowing what that impact might be. And yeah, but kind of open to, I don't know, revising our formal recommendation in the August meetings with based on that information. And I know there's a lot of discussion about what is the relevant benchmark to use, and I think I heard most comfort, and I certainly feel most comfortable with the state benchmarks. And yeah, I mean, I think based on the state benchmarks, I feel pretty comfortable with where these codes are sitting right now. And then just the question of is there a need to include coverage of one or both of the 97156 or 57.
I would definitely want to do a like a 3% inflation at least and bring it up a bit, because I think someone mentioned like there's a new process by which every single clinic has to be licensed through the state, and the fiscal impact of that is pretty substantial. Every single employee has to be fingerprinted now, and just there's a lot of overhead costs with the background checks and increased license requirements that are coming down the pike. So it would at least want to come up 3% to at least sort of adjust for cost of living, and knowing that like this group in particular has a massive shift in how operating procedures are going to look moving forward.
Kevin? You're on mute.
Sorry. For some reason, it was not working there. So I just wanted to, like, I'm just seeing a whole lot of activity in the chat. I just want to say, like, if you have a specific question, please go ahead and put it into the Q&A. And, you know, periodically, some people may be able to read the chats, but, you know, just by human nature, it's impossible to carry on like two separate discussions at the same time. So I'm sorry that we're not like engaging everything in the chat because we're having, you know, the public meeting as well. However, we do record all of that. We do like make it available, and we will hang on to it and consider it when we are not also having a separate discussion. So.
Thanks, Kevin.
Okay, I'm trying to thread the needle of what everyone is saying and put this in the chat, which is to use the Medicaid states as the benchmark, use Nicole, what you're saying as the ideal, a 3% inflation bump, a pragmatic of what you're saying, Megan, to keep rates stable, and then a policy recommendation for HICPUF to evaluate coverage of 97156 and 57 with at an 80% versus 100%, and we can discuss that at the next meeting. How do folks feel about that?
I think that's good. I also have it written, like, this is what I wrote. think that's the same or close?
I'm fine with that. Yeah.
Yeah, that looks perfect.
Okay, let me delete mine so we don't have confusion.
Thanks, Ian.
Okay. All right. Any members disagree with this recommendation? All right. Let's keep
Well
going.
done. Okay, good work. We have anesthesia next, with about 20 million in spend for 83,000 members. That's a reduction of 8%. We do have 1,800 providers, and that's very stable. Looking all in, repriced against Medicare, we're at about 84%. We have 276 codes here. Almost all have benchmark ratios with Medicare. In fact, all do, 100%. The range is 68 to 84%, but 99% of those are in the 80 to 85 range. And they count for 99.9% of the utilization. Well, you can see the overall direction here. This has been a correction of sorts over the last few years, with the decrease 42% overall the last 3 years. Kind of a broad range of top 10 codes. No one really dominates here. But these are all in that 84% range. Literally, all of them. An increasing trend from 22 to 23 in terms of provider participation, and was 63% in 24-25. The continuity is stable, with entry rate about 15 and exit about 16. Penetration rate, measuring the change of members that utilize the services per 1,000 members, was increasing in 60 out of 64 counties. Drive time puts up 93% within 30 minutes. And the PUPY expenditures decreased in 23-24 and lower than commercial payers, while similar to Medicare Advantage and higher than Medicare fee-for-service. And the Medicaid PUPY utilization was lower than other payers and remained stable. Public comments?
Yes, starting with Kathy Rasmussen.
Welcome, Kathy. 2 minutes.
Thank you, Brian. Thank you, everybody. Anesthesia is a necessary service for life-saving emergency procedures and elective procedures. From 2023 to now, the Medicaid rate has gone down from $28.63 a unit to $17.33 a unit, which is approximately a 40% decrease in payment in three years. This is a massive discrepancy from the national average anesthesia conversion factor, according to the 2025 American Society of Anesthesiologists Monitor Survey of 82.43 a unit. Using a percentage of Medicare, which rates are also under scrutiny by the anesthesia community to determine the conversion factor, is not a method used for determining ASA rates with any other entity, and has never been used to determine the Medicaid conversion factor until now, that percentage of Medicare. This is not an accurate or sustainable methodology or reimbursement for anesthesia and causes us to rely more heavily on hospital stipends, which adds further pressure to the already under pressure system. And we are asking for a fair and sustainable rate for our necessary services.
Thank you, Kathy.
Thank you.
Next, we have Megan Nash.
Welcome, Megan.
Hi, I'm Megan Nash. I'm a pediatric anesthesiologist at Children's Hospital Colorado, and one of the the president-elect of the Colorado Society of Anesthesiology. Just kind of like Kathy said, anesthesia care is not optional. It's an essential component of emergency care, trauma response, maternal health, and surgery. The biggest difference is that we don't choose we don't choose our patients, and so these findings, which is why we have so high a Medicare and Medicaid rate. There's a persistent and widening gap, including, like you said, of 2 budget cycles resulting over 45% decrease in reimbursement. Particularly here at Children's, we're having issues getting physicians, anesthetists, and AAs in our building. People don't want to practice in Denver anymore with the rising cost of living, as well as the lower reimbursement rates. And so we are asking that this disparity and continual cuts are just not sustainable in taking care of our most sick patients.
Thanks, Megan.
Okay, and lastly, Edie Busam.
Evie.
Hi, good afternoon, everyone. Edie Busam with the Ponte Busam Public Affairs, and I'm actually a proxy this afternoon for Sean Wadaway from the CEO with Northern Colorado Anesthesia Partners. I will be reading his testimony. Members of the committee, I regret that I cannot personally present these thoughts as a part of today's session. I represent a private practice anesthesia group serving hospitals and ambulatory surgery centers in Boulder, Larimer, and Weld counties. Anesthesia is essential infrastructure. Without it, surgeries do not happen. Labor and delivery units cannot operate safely, and emergency care is compromised. Our ability to maintain that coverage depends directly and in part on reimbursement from HCPF. Medicaid anesthesia reimbursement is significantly below commercial rates, often in the range of 70 to 80%. Establishing a sustainable formula for reimbursement is imperative now. We have the all-payer claims database and nationally recognized reimbursement surveys from which to use in establishing a state formula. I grant that a formula based on Medicare is an option. While sound in theory, the Medicare formula is flawed based on the time element within anesthesia services. Anesthesia is time locked, and to achieve parity with other specialties require reimbursement at levels much higher than the current Medicare anesthesia rate. I also want to bring attention to the cost associated with running a profitable group practice. They are real and continue to rise. There's a national anesthesia workforce shortage. Colorado is struggling to recruit and retain anesthesiologists and CRNAs, and low reimbursement contributes to lower wages and total rewards. Bottom line, providers are choosing states where they can practice sustainably. Improved Medicaid reimbursement is a necessity. I and others want to be part of the solution, especially in establishing a sustainable formula for reimbursement. However, further reduction in anesthesia reimbursement only exacerbates existing cost shifting. This is bad policy for all purchasers and consumers of healthcare services. I respectfully urge this committee to focus on a reimbursement methodology and solution that recognizes anesthesia as an essential healthcare infrastructure, avoids further reductions, and establishes parity with the other professional medical services based on value. Thank you.
Thank you.
Thank you. And that concludes the public comments.
Thanks, Michelle. Members?
Just a question for HCPF. Can you clarify if the rates on slide 86 they already include the impact of the conversion factor on slide 85, or is there something like different between these 2 slides?
So with anesthesia, there is a 270 some codes. And every code has the base units, which that, in addition to the timed units, are used to determine reimbursement. And then every single code has the same conversion factor applied to it. So you can see on this slide, currently, or as of April 2026, our conversion factor here in Colorado is this 1733. That's applied to all anesthesia codes. And this is the Medicare conversion factor here, also yearly applied to all codes. Does that answer your question, Ian?
I think so, yes. Thanks.
Thanks.
I think I had a similar question, and I'm not sure that I'm clear. So on slide 86 is the payment relative to Medicare with the conversion, the Colorado Medicaid conversion factor applied.
Yes, that's how you calculate the reimbursement.
So just to be crystal clear, can you click forward one slide? So this first row at 83.73%, that's comparing Medicaid to Medicare after the conversion factor has already been applied, and that equals 83.73%.
It's the total like estimated reimbursement, which includes that conversion factor, or that's factored into that. So that's the total Colorado repriced amount compared to the Medicare repriced amount. And to get the repriced amount, you need the conversion factor, the base units, and the timed units. And the same conversion factor is applied to every single code.
Okay, thanks. Any other questions from members or recommendations from members here?
I mean, I think overall as a code set, since we have, I do think that Medicare is kind of the best thing that we have to make a broad comparison across code sets and across different services. And, these do fall within that 80 to 100% of Medicare. So I think that, we're kind of in the market. I would certainly be open to seeing where we fall with respect to that benchmark if we applied a conversion factor that was closer to the current Medicare conversion factor. Like, does that bring these up to 85 or 86%, or is it something more dramatic than that?
Could you clarify when you say, so this is currently using the Medicare conversion factor, like in the comparison, which conversion factor are you asking
So
about?
I think that was with respect to the prior question. Is this the $17 Colorado Medicaid conversion factor applied, or is this the rate with the $20.59 Medicare conversion factor applied?
Yeah, so we do the Colorado one at the 17, and we compare it to the Medicare one at the 20 some odd. That's I believe the providers are talking about a national survey conversion factor rather than the Medicare conversion factor. So both of those are taken into consideration, Medicaid and Medicare, in our analysis.
Do you have any additional questions or recommendations?
I'm new, so I'm going to ask the questions just to make sure I'm up to date. So we've seen a 42% decrease in reimbursement rates for Colorado Medicaid anesthesia since 2023, correct? And then whereas Medicare is covering at $20.59 per unit. We're covering at 17.33 per unit. Is that what I'm seeing?
Yes, and you can see that how Medicare conversion factors have changed over the past couple of years and how Colorado's have changed.
Hmm.
I agree with Megan. I think our historic approach around Medicare benchmark services is a range of 80 to 100% of a benchmark, and it does appear on the next slide that we're here. And so I think I would recommend leaving the rates where they are. Does anyone feel differently?
No, I would concur with you on that, Ian.
Can I ask just one more clarifying question? What led to the decrease between like the 2025 and 2026? Was that the across the board rate decrease? Because we weren't evaluating these codes in that time frame, right? We would have looked at these in 2023, so I can see, I don't know, maybe a change from 23 to 24 being like that time frame.
There was a a set of new rates effective as of April 1st, 2026, where every single code that had a Medicare benchmark and was above 85% of the Medicare benchmark was brought down to 85%. And anesthesia was just looked at the that $20.39, because that was what was available during the governor's executive order in the fall. And that was used as the benchmark for anesthesia. So we were brought to 85% of that.
We're not at 85% of that, though. We're just under that.
Yes, because now as of 2026, Medicare went from 2039 to 2059. So we're just under the 85% now. The 2039 was used. The calendar year 2025 Medicare was used for that that change that took effect April 1st.
So it was the executive order from the governor that caused those rates to come down in 2025.
This was applied to all services.
Yeah.
Or almost all services. There were certain things that were excluded, but this was across the board. If it had a Medicare comparator.
Yeah, I think still right now I feel comfortable with sort of staying where we are, because again, like every single code we might have looked at that was benchmarked to Medicare will have experienced this reduction. We're still very much in a tough budget position, and then I think as we go through re-evaluating codes in future cycles, we'll have to take another look at this.
Sounds good. Does anyone feel differently? Okay. Let's go with that. Megan, if you could drop that in the chat for me again, that would be great. And let's go. We're going through ASCs, correct? Or
Yes.
Okay, then let's go.
Yep, ASCs are up. Here we're at 14 million in spend for about 19,000 members. That's a reduction of about 8%. With 224 providers, an increase of about 13%. Repricing that against Medicare, we get at 80%, 80.6. So we have 11 benchmark, 11 groupers, 10 with benchmark ratios, 1 is excluded. Among the groupers, we have 100% using Medicare here for the benchmarking. It does range between 68 and 102, depending on the service. But 3 of those have a benchmark between 80 and 100, and they account for just 40%. So a little tougher spread on this one. We look at the top 10 codes. We start with group 2, for example, at 77.9. That's 45% of overall utilization. Another 27% comes from the ASC group 1, that 81%. So that gets you, almost 70% of utilization. Another 10% in group 3, which is pricing in at 91%. Stability metrics show continuity about 64% with entry rate of 24 and exit of 20. 3 years, the panel size has decreased, particularly in urban areas. Number of private providers increasing while utilizers decreasing. Penetration map shows a mix of increases and decreases throughout the state. The drive time shows 89% within 30 minutes. As usual, shorter along the I-25 corridor and populated areas of Western Colorado. Any public comments?
No public comments.
Members?
My thought here is since this is a Medicare benchmark service, to bring anything below 80% up to 80% for number 1, and then for number 2 to do our same 3% inflation adjustment. It doesn't seem like there's one code above 100%, but it's just above, and it's a small code. So we would, just bring under 80% up to 80% and the 3% inflation adjustment. Any feedback on that?
I agree.
Yeah, I mean, I definitely support that as our kind of ideal recommendation. I suppose if we're like really going the pragmatic route after the last discussion, like if there was need for cost control, then I think it's the anything under 80% up to 80%. And I don't know if it's like things over 85% down to 85%, if that's kind of where everything got pushed in that change, given that this is another set of codes where everything is benchmarked to Medicare. So I feel like I'm the bad guy, but that's what I would put out there as a pragmatic recommendation. But I definitely support your prior recommendation too.
I'd be supportive of that.
The second option?
I'm
Or
ready.
both?
You're saying this, Megan, what I just put in the chat?
Yes.
That's what I heard. Members?
I can live with that.
Agreed.
We'll split the difference. Sure.
Okay.
Well done.
All right. So we're gonna pause here. Is that right?
That is correct.
Yeah, we did well. We were not sure about our pace here, so well done. But we agreed to not address dental today as stakeholders wouldn't be here, so that would be unwise and unfair.
Yes. Thank you all so much. So our next meeting will be July 10th, 2 weeks from now, same time, 9 a.m. to 2 p.m. All the materials, which are the same for this meeting, they'll be posted on the website like usual. And for the meeting summary, usually we send them out directly after these meetings, but since it's technically one meeting just split into two parts, we're gonna combine both summaries and have them available after the July 10th meeting. So just be aware of that. And I think that's pretty much it. If Ian, you want to close us out.
Yep. Or was there any other questions? Megan, were you about to say something?
Oh, sorry about that, Megan.
Yeah, I feel like this has been, or this may be another kind of challenging year. And so thinking forward to August, I'm just curious about our ability to get through all of this and revised recommendations in that allotted time frame, and might it be wise to identify a additional date and time on calendars as soon as possible if it were needed to run over.
We definitely can try if that's what we need to do. I know it's easier said than done sometimes, but I would urge us to try to stick to the current dates that we have set already. Behind the scenes, there's some stuff that we would have to do regarding the Zoom setup and everything, like certain dates might already be taken, that type of thing. So it's a little bit more complicated on the back end to kind of like spring a meeting all of a sudden. So what do we think? Do we think we need to move forward with that, or should we try to stick to, I think in the past we have been able to get through everything in that August meeting.
What happened last year? I can't remember.
In the past, we've been able to get through everything. I think we also have, I don't know, not had the ask of like really considering where we are budget wise. I think we had a few different asks for additional information to consider that's a little bit more than what we've had in the past. And I know like the first year before we set these two separate meetings for this session, like for this time of year, we ended up having to like rush and look at everybody's schedules to try and get another meeting scheduled within a week or two. And that's the reason that I bring this up now. I absolutely would love to get through everything on that August 21st meeting. And also just like realizing that calendars are tight, like want to bring that up now instead of in August.
No, that's a great call out. I think what we can do is set up a contingent meeting. So if and we don't need to make scheduling a part of the public meeting. That is actually something that we can take care of outside of like this. So if the committee members could just send us their availability for an additional meeting, let's say in the 2 weeks following August 21st, ideally the week following, because that time frame starts getting pushed up against our ability to get the report finalized and get it cleared through, all the multiple layers of clearance that it needs to go through to be a public document for November 1st. But so if I could just ask you guys to send us that, then that would be great. Again, and I guess one other suggestion I would have is that, it seems like these Friday morning to early afternoon meetings work well. So if you can make that work, that would be great. But if not, just send us what does work for you.
Okay, sounds good. All right, any other comments or questions? All right, with that, we'll adjourn. Thank you, everyone, and we will see you in a couple weeks.
Thank you all so much. Appreciate your time.
Thank
Thank
you.
you.
Oh,
See you in
great.
2 weeks.
Have a
Thanks,
nice week.
everybody.